Good morning. Hi, everyone. Thank you for joining us in this meeting regarding the COVID-19 vaccine effectiveness study. And we are very happy to meet you in person for the first time. I mean, with many of you, we were in touch for about maybe 2 years. And now this is the first time that we see each other in person and face to face, which is, we are so grateful for that. And sorry that we couldn't have it, more and frequently during the last few years. And it was, of course, that because of this COVID issues. So we were really restricted to have some in-person and face-to-face meetings. So we are so grateful to meet you here. Some of you are new colleagues, maybe you don't know each other. So in few minutes, we will do a kind of short introduction just so everyone knows each other. We will have a kind of minor change in the agenda due to an unforeseen mission happened to Dr. Arash Rashidian, who is the team lead of this project and also who is director for science, information, and dissemination in WHO EMRO. So he's on mission today, but tomorrow he will be with us. So Dr. Rashidian will join us online in a few minutes. So, for the opening remarks, we will do it later. So we will continue according to the rest of the agenda. And as soon as we have him with us online on Zoom, so we will listen to his guidance and opening remarks. So all of you know that, this, in EMRO, we have a strong agenda to institutionalize generation and use of evidence for policy making. This is strengthened after the resolution that we had in the regional committee in 2019. Within that resolution, there is an emphasis to enhance the national capacity for generation and use of evidence for decision making at the country level. So after that, there are many activities, projects, and programs happened and ongoing regarding to enhance this capacity within the region. And tomorrow we will have 2 other sessions that we will explain in details and more about what we are doing here in EMRO and also in WHO as a kind of an organization to enhance and to institutionalize this capacity within the countries and how we are going to support countries in that regard. So we will discuss this more tomorrow. So I'm not going to explain and go to the details of the agenda for evidence-informed policy making, but today and tomorrow, our main focus and the main focus of this meeting is to discuss the COVID-19 vaccine effectiveness study. This was the request from our directors. You know that during the COVID-19, we had incident management support team that we called it IMST in WHO. And there were directors and also all technical programs participated in these meetings. We had a strong request there to do a regional COVID-19 vaccine effectiveness study, to have and to produce some local and regional data and results on vaccine effectiveness in our region, because there were very limited studies in our region regarding vaccine effectiveness and also particularly on COVID-19 specifically. So it was a request to do that. And based on that, we planned for this regional committee. There was a long story, long efforts that I'm so happy to my colleagues. Kamal as my best friend and colleagues, as a core team, and also Zahra, that I'm so sorry that she cannot, attend in person with us. So in that case, we started a long process to initiate the regional COVID-19 vaccine effectiveness study. Later, we will have a presentation to explain a bit that what has been done so far, and also what were the steps that we took to have this regional COVID-19 vaccine effectiveness happen. So I think that we can start with the first presentation. about the meeting objectives. So, I mean, we discussed this since morning, but again, maybe very quickly I can go through that. If you can just, thank you, put my slides, thank you. Okay, shukran. So, I very quick, I will just go through this meeting and also the agenda and the technical sessions that we will have. Please, next slide. First, as we all know, the main reason to have this meeting is to share our experience and knowledge with each other, and also to see how we can support each other. I mean, not only the countries who has representatives here, also other countries in the region, how we can support them to enhance and to build capacities for conducting similar studies in future. And also we need to hear from all of you about your lessons learned and how you think that, WHO can support this kind of works and activities more in the future in the region. So please, next slide. So for today, we will have some technical sessions. I mean, in the first session, we will explain more about what we did regarding this regional COVID-19 vaccine effectiveness study. And also we will hear from colleagues in headquarters about the protocols, WHO protocols, and the, update revisions that happened, regarding the protocols during this COVID-19 pandemic. We will have a session to listen to those regional studies from Jordan and also from Iran, regarding the studies that used SARI method, test negative design method. And then we will listen to the studies from Pakistan and, Jordan and, it's the cohort. Yes. And then we will listen to Egypt and Pakistan for cohort, for the studies using cohort method in healthcare workers. Then we will have the results from other countries that, they have been done, independent from WHO. I mean, the other countries also in our region, they did some studies regarding COVID-19 vaccine effectiveness. So we will listen to their methods, their challenges, and also their lessons learned. And then we will have a kind of closed session just internally with WHO colleagues to just discuss more about our challenges in WHO and how we can enhance our capacity, our regional capacity to do these kind of supports more to the countries in the region. So please, next slide. And tomorrow in the morning, as I mentioned just earlier in the morning, we had a kind of support, thank you so much, during the COVID-19 for our countries, not just for vaccine effectiveness, for conducting any kind of other types of studies like clinical trials. We had some solidarity studies. So tomorrow we will use that session to explain a bit more about other supports and initiatives that have been done during the last 3 years by WHO in support of research evidence for COVID-19. Then we will have a great session on a statistical analysis, which is, I think that this is very important for us because many of us, we are in the last stage of our studies, and it's very important to see what are the methodology regarding the statistical analysis and how we can do this analysis to have a valid data and results to be used for policy making. Then we will have a session, and we are so grateful to the efforts Kamal and Komrol and also Dr. Ivan, Director for Communicable Disease, done so far for having this session. This is the colleagues from NITAC and RITAC, National Immunization Technical Advisory Group, and also regional Immunization Technical Advisory Group members. Some of the members and chair persons will be with us tomorrow. And this session is, the reason to have this session is to see, okay, now we have some results, we will have some local data, we will have some regional data, but how we can just, what are the roads and how we can, what are the means to just inform and policymakers in our regions for using these results. So, and this is not just for this COVID-19, this is exactly for all. I mean, future, how we can support policy making, I mean, immunization, regarding immunization policies, how we can support them by having local and regional evidence on time. And then, we will have, as usual, we will have closing remarks. I mean, today and tomorrow, we have some sessions for discussions and question and answers. So during those sessions, if colleagues, you have any comments, idea, opinions, feedback, questions, so please just share with us. This is the momentum to share, I mean, our opinions and to have more, to get more knowledge and more experience from each other. Okay. So I think that we did that introduction, so no need to go to this list, but as I mentioned, we have different and variety institutions and organizations. Also, we have colleagues from Ministry's office, we have colleagues from WHO, not just regional office, other regions, as we have Francisco from PAHO, and we have also colleagues from headquarters with us. And I think that this will be, and these are the presenters for today and tomorrow, that you can see also the agenda. I think I can stop here. And if there is anything that, Kamal, you want to add, otherwise we can go for the first presentation, please.
Thank you very much, Mernaz, and thank you again for joining us in this very important meeting. Actually, you can see how this meeting is important, reflecting all the work which has been done to work on and to raise the issue of vaccine effectiveness, which has been actually emphasized during the COVID-19. But we all know that vaccine effectiveness is also related to all kinds of vaccines, and we will have an opportunity to go through some details how this vaccine effectiveness as one of the principles when it comes to decision-making for either introducing a vaccine in a country or modifying a presentation. So these are elements that would be taken in consideration and it will be detailed in the presentation tomorrow. But as Mernaz said, this is a very important forum now to have your reflection, to discuss more and to get more into depth of what you're seeing from the country perspective in relation to the vaccine effectiveness and how it has been worked during COVID and how it will be worked also for other vaccines. Most of the countries in the region are in a phase or another of introducing new vaccine. Introducing new vaccine is a continuous process, and almost all the countries has new vaccine in the radar to be introduced. So how the National Immunization Technical Advisory Group will be considering the introduction of these vaccines? There are a lot of evidence based in order to help the decision to be able to have these vaccines introduced in the country. Beside the financial one, which is a major portion and chunk for introducing any new vaccine, because it entails sustainability of this introduction of the vaccine. And we know how much the vaccine could be expensive for a country or another. Although we know that there are a number of countries in our region are supported by different entities and bodies to support introduction of new vaccine. But when it comes to technical side of decision-making, we need to raise many important things, like, for example, doing cost-effectiveness analysis, do impact analysis, doing burden of the disease. We can do many things, but one of the most important things, how this vaccine is effective. Vaccine effectiveness is different from vaccine efficacy. Vaccine efficacy is done by the manufacturer or in an ideal stage presentation. We know that we don't have this ideal stage. That's why we do what is called vaccine effectiveness after being introduced in the country to see how this vaccine has been effective in preventing a disease, infection, transmission, severe form of disease, intensive care admission, or even death. We will go through all these different areas that we need to discuss together to see how we can be of more help at a regional network here to all the country present in this meeting room or present or joining by teleconference. But also we would like to emphasize that we have 22 countries in our region and we are here to support all the countries. I'll stop here and then we'll go to the next part of the agenda. Thank you.
Thank you so much. I think that, Zahra, I think Daniel, he may join us a bit later for his presentation. So we can go for our presentation first, because as I'm informed, Dr. Arash, he will be with us at 9:45. Then also we can just listen to his opening remarks as well. So in that case, if Amar, you can just put my second presentation. Yes, please. Thank you. Okay, thank you so much. So, we did a kind of change in the agenda. So we will go for this presentation first, which is about overview of the Eastern Mediterranean regional COVID-19 vaccine effectiveness study and establishment of the EM regional COVID-19 network, vaccine effectiveness network. So myself and Kamal, we will give this presentation, and after that we will go for other presentations which is scheduled in this session. So I don't know why this control never works. There is an issue. I mean, this is the nature of this. Okay. Okay, why we did this regional COVID? I said that this was a kind of request from IMST team in WHO, but why we really had this request? If you remember, during the COVID-19, mainly in the, early phases, we just had the results from results and data from clinical trials, and there were really limited, results from vaccine effectiveness kind of real world data. So, and in that case, the results, they were available, they were from mainly other countries, European countries and other regions, and there were limited data from our countries in the region. Also, in addition to that, we had studies on some specific types of vaccines. And for example, when it came to Sinopharm, for example, there were really rare studies about their vaccine effectiveness. I'm talking about the real world data. And in our region, in addition to all this, in our region, we had several vaccines which were domestically produced. For example, in Iran, we had many other vaccines that just was produced by the country, and there were no data about their effectiveness. So, apart from data from clinical trials. So all these, there were all the reasons that we thought that we need to have a kind of regional vaccine effectiveness study, to have some regional data on the vaccines that there is no data about them, and also on vaccines that there is data, but this data is from other countries, is not from our countries.
Thank you so much. I'm so sorry for the
mistake. Mute yourself.
Yes, I shared the slides and they were projected. And if you feel like you want to do it, you could also ask them. But
Zahra, I think you need to mute yourself, please. Okay. And so there were the results, the reasons that we really thought that there is a need to have some regional study, but also we realized that even the history of having such studies in our region, not about COVID-19, about vaccine effectiveness, is really weak. We don't have a strong history on conducting such studies in our region. So all this just was the reason to plan for a regional study, to have some local data. As we always say that, to inform local decision making, we need valid local data, but of course not, as I mentioned, valid local data. When we want to have local data, it's very important to pay attention to quality assurance, of generation of those data to have robust and valid ones to be used and to inform decision-making processes in the country. If I categorize what we have done so far for this study, I can categorize them in two main categories. One of them is what we did to enhance the processes and structures, and what we did to enhance and strengthen and build the capacities, the technical capacities. So for enhancing the process, I mean, in my future slides, I will go to some of them, I mean, in details, and I will explain more about them. What we did at the beginning, we developed a dashboard to just regularly update ourselves about the studies, not just in our region, also the studies which done by other countries in other regions, and even the studies that were just planned to be conducted. So we wanted to know that, for example, what types of methods are common and are being used by different countries. What are the results? If there is any results available, if there is any challenge available, if there is any knowledge shared there. So we developed our dashboard, and we regularly updated this dashboard. And this was just for keeping ourselves updated about what's going on in our region and also in other regions and other countries. Also, as I mentioned, that quality assurance is very important to have and to generate and to produce valid data. What we did, we tried to standardize all processes. For example, our study designs, our code books, for example, our data analysis. So whatever that we can do just to have a unique methodology and process for conducting this study in the region. We issued a regional ethical clearance. This was, in addition to the national ethical clearance, and we did this to just make sure, I mean, the protocol that we had, it was reviewed by our regional research ethics review committee to make sure that everything, is, respected, and, we consider all critical components in this study. We developed the regional platform, data entry platform. This was the main of having that was because, of course, that we need to have some national data, but we need also to have it in a way to pool it, to generate some regional data, which can be used by other countries in our region. So for doing that, we developed the kind of platform, data entry platform, which is RedCap, and we had some sessions with colleagues for capacity building, that how we can use this RedCap. We think that this is very easy platform for data entry, and also all this we try to do in a sustainable way. I mean, after this regional COVID-19, our network, this platform, everything will be there still for future studies, for future regional studies. So we try to do all these things in a sustainable way to also have this platform again available for our future studies. Also, we established, I can say, we formed a regional network which includes a technical team, which within that technical team there are I can call it multidisciplinary team, because we have epidemiologists, we have health economists, we have public health specialties, we have lab expertise, we have different, expertise and experts within this technical team. And I will show you also our network, that it includes regional office, country office, consulting team with us. Regarding capacity building, I think that the countries who, I'm talking about Egypt, Pakistan, Jordan, and Iran, you are aware of the different types of capacity building programs that we had. We had some region-wide workshops that were open to everyone. And I'm so happy to just mention that we had more than 500 participants totally attended in our online workshops, and we had country-specific workshops. For example, if we received a request from Pakistan, Egypt, that they have a specific issue regarding use of, for example, RedCap or data analysis, we did a kind of separate tailored workshops for countries as well. Another thing that we also supported, it was, adaptation of the generic questionnaires to the national context. That was very important to us.
Yes.
Yeah. That was very important to us, because there were some generic questionnaires, but not all countries were able to apply the same questionnaires. So what we did, we just worked together and we supported countries to adapt those questionnaires to make them appropriate to their context and to their setting. And also we did some site visits. For example, we did just recently one in Egypt, which we were very grateful to what we saw there. In terms of commitment, support, and enthusiasm in doing this in such studies in the Egypt. So and also we had some site visits in Jordan and Pakistan with country office colleagues Michael and Savario as well, that you can explain later about your experience there. So just please let me know when Dr. Arash is online, because I cannot see when presentation is open, I cannot see the name. So when he's here, just please inform me, okay? I will.
Dr. Mehnaz, if you can hear me, I'm already here, but please finish your presentation. I was actually listening carefully. No, please go ahead, finish your presentation.
And Dr. Arash, it will take time because this is my presentation and we will have, it's a bit long presentation. So if I know that your schedule is very tight also there. So if you wish, you can just please go for your opening remarks, and after that, I will continue for the rest of the presentation.
Okay, very good. Many thanks. So can you see my video as well? Because I cannot see that on my mobile phone.
Dr. Arash, we can see you now.
Okay, many thanks. Good morning, Sabah al-Khair, bonjour, Sobh al-Khair. It's a pleasure to be with you and also to be able to join remotely. I'm grateful to Dr. Kharandish for starting the meeting and for all of you to be in this important event. Of course, before I start saying any words, I need to say my apologies for not being with you in person. So due to an unforeseen mission requirement that wasn't part of the plan, I had to join our Director of Planning Management, Dr. Rana Hajjet, for an important mission. But I will be back in Cairo in the evening, and I will be with you tomorrow, inshallah. So I see you all in person. So obviously, I was listening in the last 2-3 minutes to the presentation of Dr. Mehnaz, and then she was actually recalling and highlighting the key activities that have been done. But what I want to say, perhaps as opening remarks, are some looking further back in terms of how we started this work together as WHO, the support program, and why has been a very important endeavor for the WHO in the region, and perhaps for the work at the country level, and then how it can have implications for future work, that the way we take this forward. You all remember, the years of the pandemic in a way has become part of the life, has been so exceptional, so different, that most of us, this is definitely the case for myself. So sometimes I look at those years as the years that were as if they were not part of the normal life. But then that disease, that pandemic, changed a lot of things in terms of how the health system worked. There were so many questions we did not know the answer. And then we also realized there were so many research-related capacities that, our region was not very strong in. So as WHO, we started working with countries and identifying the capacities, the areas of excellence, the teams that can work further in these areas, and supporting vaccine effectiveness studies. At the same time, several of you have been part of the studies in your own countries that you've done it independently from the WHO. Again, these studies, some of them have been very highly cited at the global level in terms of sources of evidence during the pandemic years. They've made a sort of an impact there. For us as WHO, again, engaging in such high impact and large scale studies was also exceptional. I mean, within the years of the pandemic, again, all of you remember the WHO hosted the Solidarity randomized controlled trials for identifying effective treatments for the COVID-19. And within that, again, I mean, several of the countries of the region very active, at least 4 or 5 countries were very active. And some of you who are in the meeting were actually part of those network as well. Again, that was a sort of as part of an exceptional work from the WHO. The vaccine effectiveness, however, was very important for our region, especially this design of vaccine effectiveness studies were actually quite rare in our region. Not obviously I'm not talking about vaccine effectiveness for COVID-19 vaccines because that's a new problem and a new sort of disease and a new set of vaccines that we needed evidence on. I'm talking about all communicable disease studies. I mean, largest vaccine effectiveness studies were really rare in our region. For WHO, one of the reasons as part of the WHO response to the pandemic, was that to enhance the capacity to support the countries to make sure that, first of all, there is evidence coming up from countries of the region on effectiveness of the vaccine, especially as some of the vaccines being used in the region were not the vaccines that had been studied widely in other countries or other settings, but also doing it in a way that the capacity at the regional level is expanded so that this capacity will be used in future for other vaccines, other programs. So in a way for us was a sort of responding to the question of the day, but also preparing ourselves and the capacity for the questions of tomorrow. And that's the way, I mean, this important endeavor was planned. And that's why, I mean, the key teams within the regional office and within country offices of the WHO were heavily involved. And we received also very strong support, technical support from colleagues from HQ, I mean, the sort of the global team of the WHO, and also from external experts in the area, and that some of them are with you in the meeting. And sort of all those have been part of the package of the work. At the same time, I mean, for us was important to bring all this together. So, I mean, I'm really delighted and grateful to Dr. Khairandish. I'm grateful to all colleagues in the meeting. So, and the teams from the Science Information Dissemination Department and also the team from the Communicable Disease Department who've been supporting this agenda. From my colleagues in country offices, my colleagues from the headquarters, and also all of you who've been involved in doing these studies, checking the quality of the work, I mean, enhancing the work together to come together. Because for us, this 2-day meeting is not only looking at what has happened and the results and the next step, is also to think of how to use this experience further in 2 areas. I mean, how we can sort of shape the future work of the WHO in these areas. And then also to bring it closer to the discussion of policymaking related to vaccination policies. And that has been also another key area of work for the WHO. I mean, you are aware, I don't know whether that has been part of the presentation that Dr. Mehnaz is making or not. So, I mean, there is an evidence-informed policy making agenda in the region starting from 2019 that actually Mehnaz is leading that in the region. But also there is an important policy-making program that is supported by the colleagues from the Communicable Disease Department. I mean, I see Dr. Kamal in the meeting, but there could be also other colleagues from Communicable Disease Department. And this area is related to the national immunization policymaking and also the regional consultation on policymaking. And one of the sessions in the program is related to how to better use the vaccine effectiveness evidence in national policymaking and in regional policymaking related to immunization. So for us, taking all of this together. The other thing I want to highlight, and this is again strategically about the importance of this meeting and how we are linking it with the other agenda, is that just after this meeting, so I mean, today and tomorrow, we are hosting the meeting on vaccine effectiveness studies. My department, another team from the department, will be hosting another consultation from on Tuesday and Wednesday. And that one is actually looking at the larger scale studies that are related to health and how WHO can help support and what should be the role of WHO for such a study. So obviously vaccine effectiveness studies are sort of, I would say, a specific case of the support. But then we are talking about randomized controlled trials as in all areas of need, I mean, priorities for the region, but also, for example, cohort studies, etc. So I'm hoping by the end of this week, I mean, listening to the expert, listening to your expertise and your wisdom, we would have a better idea of how to shape the agenda of the WHO. And in particular, how to shape the agenda of the department that is my responsibility, science information dissemination, to support countries of the region in areas of priority. So while I mean, a lot of the deliberation is specifically on the studies that have been conducted, sharing experiences, learning from each other, is also, I'm also seeking your advice and wisdom to tell us what do you think should be done also in the next steps. Again, my apologies that I'm not with you here. I'm also grateful for opening the session for my interventions. I mean, interrupting your the flow of the work that you are doing. And I'm looking forward to meeting all of you tomorrow. So by that, I stop here. Wish you a very sort of engaging and warm and sort of successful day, first day of the event. And turning over the microphone to my colleague, Dr. Khairandish, and if there is any question or any intervention at this stage. Over to you, Mehras.
Thank you so much, Dr. Arash, for your excellent opening remarks. And we are really looking forward to see you here in person tomorrow with us. So if there is any question, I think Dr. Arash, you know, he has to leave the meeting. So if colleagues, you have any question? Okay. Thank you, Dr. Arash. Thank you for joining us.
Can I intervene? Can I intervene?
Yeah, please, please.
Very briefly. Yeah. Hi, Dr. Arash. I am Dr. Rizzuddin Mohseni. How are you doing? Great to see you. So I'm very glad, actually. I'm talking on behalf of RITAG. I'm chairing the RITAG in the region. And can I remember that in the our last meeting, we highlighted a lot this issue of building the capacities in the region. I'm very glad, and I would like to salute this initiative from the regional office. I'm very glad to see that it will not stop there. This is a starting point. And as you said, we need to develop the capacity of our country. We have a lot of issues that needs to be done. So perhaps we'll have more discussion tomorrow, just to say hi and thank you very much for this initiative. Thank you.
Yep. Thank you for the nice words. And I'm looking forward to meeting you and other colleagues tomorrow. Yeah, many thanks.
Thank you so much, Dr. Arash. Thank you. So have a nice day.
Okay, thank you. Shukran. Bye-bye.
Shukran Gazila. Okay. So Amr, I think you need to put again that previous slides. So till my colleague is just putting the slides again. So we have our two new colleagues. I mean, not new colleagues, I mean newcomers. So please introduce yourself, Dr. Nabi.
Yes. Good morning. Sorry for being late. I spent a lot of time in parking and I parked far away. But I am Professor Zainab Nabil Ahmed Saeed, Professor of Medical Microbiology and Immunology, Faculty of Medicine for Girls, Al-Azhar University, and the PI of the Egyptian study.
Please.
Thank you so much and good morning, everyone. I was connected online and I was trying to unmute. It was a tech issue, but I'm glad I'm here with you. My name is Farida Mahgoub. I work at the IHP unit in the WHE Emergencies Program, and I'm very excited to learn about the very rich experience that you've all shared preparing for these studies. Thank you so much.
Thank you so much. So let's now just continue the presentation. I hope that you remember that I said that we developed a dashboard at the beginning to just update ourselves about the studies, conducted or ongoing in the region or other regions, other countries. So this is just a snapshot of one part of this dashboard. As you can see, so in the left side we had the countries, and in the columns different characteristics and different specification of each study, and if there was any study published online. So we added also the link for the study just for ourselves to review and to see that what's going on in other countries and other regions. So this is also another snapshot of the dashboard. And for the ones that we used for the global one, the source was the View Hub, which WHO generally use that one for this purpose. And also, as I mentioned, that we developed and created the data entry platform in RedCap. Again, as you can see here, we had RedCap and we had different sections and I can say pages for countries. For example, we had one platform developed for Egypt, one for Jordan, one for Iran, and one for Pakistan. And colleagues, PIs, they had access to this platform to enter their data. And we had several rounds of validation, check of the data. And this was happened many times during I can say at least during the last 2 years, and mainly during the last 6 months. I can say that we weekly did this kind of update and check to just to assure the quality of the data and the validity of data there. So these are the 4 countries, the participating countries in the regional COVID-19 vaccine effectiveness study. We have Egypt, Iran, Jordan, Pakistan, and 2 of them, Egypt and Pakistan, they use the cohort method, and Iran and Jordan, they use test negative design method. So I'm not going to go through the details because in the coming sessions, we will go through each of them by PIs in details. So it's better to skip this slide. As I mentioned, we had several region-wide and country-specific tailored workshops. And I just want to mention that if you are willing to see these workshops, the materials, including the presentations and recordings of all these workshops are available through EDP webpage. My team webpage, Evidence and Data Policy Unit webpage. I have put the link here in the next slide, so that we will share the slides with you. So we would be also grateful if you even share this link to other colleagues in your institution or in your network who is interested in evidence-informed policymaking, who is interested in similar studies. So I think that there are a lot of good information and knowledge there to be shared with colleagues. So as I mentioned, that we had a multidisciplinary technical team here. So, we have many colleagues there. So we have core team that, as I mentioned, I'm so grateful to Kamal and Zahra, who is with us online today, unfortunately. So, and we had team leads. The Dr. Arash Ashidian, he is the Director of Science Information Dissemination in the WHO EMRO. Also, he was a lead of RKM, Research Knowledge Management Pillar team in IMST in WHO, and he also was the team lead. He is a team lead for this project. And also we have Dr. Ivan Hutin, Director for Communicable Diseases, and who is also the lead of Vaccine Pillar in IMST as a co-lead for this project. We had other colleagues from other departments, WHE departments, and other colleagues from other units in SID division. As you can see their names here as supporting technical team. And this is a place maybe that I can also thank our former epidemiology consulting firm, EpiConcept, that there were colleagues, you know them. We had colleagues with us from the beginning for 1.5 years, I can say. We had these colleagues from EpiConcept as epidemiology consulting firm. And now we have colleagues from Global Health, MMGH. That Manuela, she is with us here. Carson and Thomas, they are hopefully with us online, and Julio and Natalie also, other colleagues there. That these are also colleagues who have been supporting in terms of epidemiology kind of data analysis and statistical analysis. So I can show you here, when we talk about network, this is a network. As I said, that we have that multidisciplinary team. We had focal points from country offices, Jordan, Pakistan, Iran, and Egypt. Also, we have our PIs from the 4 countries. So this is, I can say that this is our consulting, epidemiology consulting firm. So this is the network that we have, which is, I can say, I shouldn't say that, but I can say that this is very active network, really. I mean, when I compared, yes, when I compare to other networks that we have, this is very, very active. As you said, overactive?
Interact.
Yes. Okay, so in terms of the quality assurance, so as I mentioned, so we tried to standardize our study design, the methodology for doing the study, also the data analysis. We developed a kind of code book to have a unique code book to be used by all countries. And also we supported adaptation of the generic questionnaires to national context. And as I mentioned again, the regional ethical care. So all this not just done to make sure the quality of the process and also the consistency of the work that we are doing, and just to make sure that at the end the data can be pooled to be used for region, to have some regional also input. There were several activities and programs that we had in terms of to facilitate, I can say, data sharing. I know that maybe some of you just exhausted of having too many weekly technical meetings with us, but I think you see now it was helpful. Yeah, it was. Yes, thank you. So we had a kind of, I can say, at least weekly. I mean, sometimes we had, bi-weekly something, but we had weekly meetings with colleagues. I mean, it was, a part of daily email exchange with colleagues. So we had different workshops, as I mentioned, different trainings, site visits, and frequent data check in the red cap. But this was the way that now we think that we have robust and valid data to inform policymaking, and we are so happy to did this together. So as also Dr. Arash, he mentioned in his kind opening remarks, so we did this to build or to enhance capacity in our region, within our countries. And it's not the end of the work. Of course, we will continue. So whatever that we did, all platform, dashboard, everything, they will be, existing forever. So this is something that we can use in future for other studies. So because of that, we have colleagues from WHE, we have colleagues from DCD. This is the joint project and joint activity. This wasn't something just for occasionally for COVID-19. We really try to do that in a way that to have some infrastructure here for build up and for other studies in future as well. So I'm so grateful for all, I mean, your collaboration and your cooperation for this process. And also, of course, we just not generate data to have some data and results. We want to see how we can use it. And this is the part which is, I will explain tomorrow about my role, my main role as regional advisor for evidence and data to policy. So my main role is how, when we have some data, how we can use them for policymaking, to inform policymaking. So this is the main goal for us. That, okay, so there are some data, but we know that not all countries, not in all cases, really our policy makers pay attention to this data. So this is the reason that tomorrow we will have session with NITAC and RITAC members to see how we can make this link and how we can just use this produce data for policy making. And as I mentioned, there are these sources. You can find whatever that I just mentioned so far regarding our trainings, capacity building programs, and details of whatever that we have done. So you can find not just only on COVID-19, also regarding evidence-informed policy-making agenda. So whatever that we have done, you can find using these links here. And we would be very grateful if you share these links with your other colleagues in your networks or in your institution. I will stop here and I will just over to you, Kamal, please. Thank you.
Thank you very much, Mernaz. Actually, we have seen all the steps that have been taken during this study from the early beginning until today. And as we know in our lives, there is no easy life. There is always some challenges here and there and bottlenecks. And Mernaz has shown in one of the slides just 4 circles of interaction. And the interaction was really within this building of WHO EMRO and also with the country. On the other hand, it was also another teamwork within the country. So how to put everything together, it wasn't really easy and necessitate a very collaborative team, which I feel lucky to work with Mernaz and Zahra working on that. But I was just wanted to add 1/5 circle that will come in the future, because as Mernaz was saying, this is the steps which have been taken and then looking forward for the next step. The next step is the 5th circle. This 5th circle is the decision maker. We need to have the decision maker on board because we have a very elegant group of researchers here. We have people from different 2, 3, 4, 5 departments in this building. But where are the decision makers? That's why the next step will be having the decision maker within the country to say yes or no, or not now, or maybe next year. And that's why we have an eminent person joining us in this meeting, Dr. Izzeddin Mohseni, who was my ex-boss, and a very prestigious person, not at a regional level, but at a global level. He is member of SAGE. SAGE is Strategic Advisory Group of Expertise who give the global recommendation for vaccines. So we need the people at the regional level, all the RITAG members, 10 members in this region giving advice to the region, as well as the NITAG at your level, the National Immunization Technical Advisory Committee in the country to take these studies. And as mentioned, the role of Mernaz is to make sure that these people, decision maker, are taking in consideration the data. And as you might know that since the last year, there was what is called an Immunization Agenda 2030, which is the roadmap for immunization for the next 10 years for the whole world. One of the most important principles in this immunization agenda is to be a data-driven. We need to decide upon evidence, upon data. So this is actually the unpleasant part of the presentation related to the challenges, but this is life. We have all challenges and we are not, and Zahra actually has put a lot of work not to reflect all the challenges, not in order just to motivate you, but it has been a lot of challenges working together for these last 2 years for the network of the study. And here we are classifying generally the challenges into general challenges or specific challenges encountered in country level, or unique challenges when we are going in the deep dive of every vaccine effectiveness test. So these are a number of general challenges that we have met, but as I'm saying, challenges is a part of our life. So it is not a problem to have challenges, but the problem is not to overcome the challenges. And I would say before going to this list of unpleasant challenges and bottleneck that we have all succeeded as one team to overcome all these challenges with your help at the country level, as well as the coordination and cooperation within this region. So we had the changing landscape of COVID epidemiology during the implementation of the study. Also, it should be understanding that this COVID-19 vaccination was not a simple vaccine like other with already established doses. No, there was many types of vaccine, huge number of vaccines. Some of them are locally produced, like the vaccine which have been produced in Iran, for example, and some other global vaccines. Some of them is 1 dose, some of them are 2 doses, and as well as the background of every vaccine, they are different in structure. So every country need to do a decision. Are we taking this one or that one? So this is a complex vaccination program. The cost-benefit value for use of certain tests in the evaluation of vaccine effectiveness. This was also a challenge that has been considered during our studies. Possibility to reliability use of less expensive alternative in resource limiting settings. Unfortunately, as you know, in our region, we have a very big number of countries. I would say that more than half of the country are in a situation, not only of conflict and war, and our heart really going to our colleagues in Palestine and Gaza for what is going on. But I'm just saying that half of the countries in our region are facing a conflict in a way or another. And when it comes to conflict, it comes with a resource limitation. So how we can prioritize? We have some countries here, or even middle income countries, are not prioritizing one of the most important vaccines because the resources are limited. However, some other rich countries, they have no problem whatsoever with financial sustainability of any vaccine, and they are introducing all the vaccine, whatever it is. So we need to consider this disparity between the countries in our region. And the use of the new platform, which is the RedCap, which is the research data capturing platform. This was not the platform which has been used in the beginning. This platform is very useful for vaccine effectiveness because it is one of the few number of platforms that can encompass the follow-up data. The follow-up data is not easy to be introduced in other platforms, whether Excel, whether Access, whether CSTAT, whether Stata. So that's RedCap platform has been used at the beginning, and we have been facing, and thank you again to all our colleagues in the country helping us in the WHO country office as well as the team to start accommodating this RedCap, which has been at the end of this study being very useful in generating data. When it comes to specific challenges for individual country, we are not mentioning any name of the countries, but you should be understanding that we are not only talking about the 4 countries which are present here in the vaccine effective network, because you have seen in one slide of Mehrnaz that there was where the dashboard is. You remember this slide of dashboard with all colors and this very big number of columns on the left side. There was a very big number of countries. So we started our support to all these countries throughout this period, the pandemic area. But we continued with data manipulation and data working only with 4 countries. So there was inadequate access to necessary infrastructure or supply in some of the countries. But we have been able, with the presence of our PI in the countries, to overcome this challenge. In some countries, the study has been interrupted for a while without going into reasons. Missing data, the difficulty of tracing and tracking of study participants. We all know what happened to the people in the countries during this pandemic with vaccine effectiveness, with refusal, with hesitancy, with non-continuation, and with many other things. So we faced this also. Inability to reach the adequate target, which has happened in a couple of countries, but this has been overcome in the analysis. Amendment and adjustment also of the study design with a bit of tweaking of the design, because we know that we have 2 approved protocol by WHO, either the CND-SARI or the prospective cohort for healthcare worker, but there was a kind of tweaking in order to customize the situation for every country, as it has been done for the questionnaire. Has mentioned that even as a part of the study, the questionnaire has been a bit tweaked up, and there is nothing wrong in that. We can adjust any study according to the context of every country. The data management and interoperability with standardized platform, we have seen that also. And as you know, maybe with the people who are much more involved with the data, how difficult to transfer data from one platform to another. It seemed that could be a click of a mouse, but the work coming after to clean the data, to validate the data, takes weeks and months. Some challenges were related to specific study. Inability to standardize the study design and methodology for the technical proposal. So we have been a bit adjusting the design of the study in this specific country in order to make sure that we will be able to have this standardized. We need to understand that in this regional platform, we have a vaccine effectiveness study per country X and Y. But at the end of the day, what we are looking for to put all these data together to come up with a regional one, and maybe this will be discussed further by Manuela from MMGH. In difficulty in importing existing electronic platform, very, very difficult part of data management. The difficulty in obtaining the necessary authorization and approval. We have been facing in a country complete stoppage of everything only because we need to have this ethical clearance from the country, and this is something that we don't have any control, neither us from the regional nor the PI, because it should be coming from the ethical committee in every country. Difficulty in securing adequate funding to support some individual studies. We have been facing this. And in parallel, I just wanted to let you know that all the team who have been working or named as a core team here have been working also with the leadership of Mernaz to work on some other non-technical issues. You know that in any study, we have a technical part, but we have a big administrative and a big financial. So there are some other challenges that we don't want to go into detail in this forum related to financial sustainability of this network. Future need for implementation. We need to share this experience. We need to have this country input, not only for COVID-19 vaccine, but for also other vaccines. We need to leverage on the presence of the NITAG in every country as well as the RITAG, and we are happy we're having Dr. Azzeddin with us to leverage this. He is working very hardly to get this connection between the decision maker, which is the next step. Because vaccine effectiveness is a study. Is studies that we are doing to come up with a figure that the vaccine effectiveness of this vaccine is such. We will be seeing a lot of statistical analysis, but at the end of the day, how we'll be using this kind of data for decision making. Linking the disease reporting with vaccination history and health outcome, and as we're going to see that the vaccine effectiveness might be to test the vaccine effectiveness of specific disease to a specific health outcome. Some of them are easy, some of them are a bit problematic. We need to have a closer collaboration with RITAG and NITAG, as I have mentioned. We need to have successful service delivery model and integration in the primary healthcare centers, because now we are talking everywhere in the world, there is no standalone immunization program, but it is a part of primary healthcare. So how we can get the people of primary healthcare program knowing more about vaccine effectiveness in order to have an integrative approach. We need to maintain the EFI reporting system, the adverse effect following immunization, which is a concrete part of every vaccine. The vaccine might be effective and it has a high effectiveness, but what if it has a serious adverse event following immunization? Are we still introducing the vaccine? The NITAG has a word in that. We need also to have the financial sustainability for the vaccine supply, which is a major challenge for many countries, not only from the manufacturer perspective for producing vaccine, but also for the country to purchase those vaccines. Would like to thank you very much, and we'd like to hear from you. This is an interactive meeting, and we need also to learn from you. Thank you very much.
So today I'm coming at the beginning of this meeting. I'm going to go back a little bit in history and talk about what we've been doing at WHO headquarters. I'm in the Department of Immunizations here, and I've worked with many of you in the EMRO region through the last 3 years, really, and coming up with vaccine effectiveness methodologies and other work. And it's interesting to look back at sort of some of the things we thought at the beginning that have changed now. I'm going to end by talking about what I think are some of the more pressing issues today in executing vaccine effectiveness studies. So next slide, please. First, let me just ask, is my sound coming through okay? Great. Okay, so I want to start just by, I mean, this is something that I think we all know, and I want to remind everybody and remind myself is that we've done so much work with vaccine effectiveness, but vaccine effectiveness studies are observational studies, and we are always trailing behind randomized controlled studies. In observational studies, we have lost the magic of randomization. And so we're always trying to catch up with what has been done or could be done in a randomized setting. And as many of you know, that is really the essence of doing an effective vaccine effectiveness study, is trying to get as close as we can to a non-biased randomized study. And much of the work we do is in that effort. Next slide, please. So I think some of the reasons why we do vaccine effectiveness studies have been mentioned by Mernaz and Kamal. I think in particular for COVID vaccines, what we were facing back in early 2021 is randomized controlled trials for these vaccines that had a very short follow-up period. I'll remind you that those studies followed people for at the most 3 months after vaccination. And they were looking at symptomatic COVID disease. They were not looking at severe disease. They had few elderly people. So many of the most important questions were not going to be answered by randomized controlled studies. So we knew that we would need to do good post-introduction vaccine effectiveness studies for multiple reasons that you can see here. In addition, I'll remind you, at the time, none of these vaccines were licensed. They were all given emergency use listing. So the regulatory authorities required vaccine effectiveness studies to show that these vaccines were working in real populations. And then there were many, as we went forward, there were many surprises. Next slide. This was, I would say, in retrospect, the biggest one is we were not expecting the type of variant emergence that we saw. And we really didn't know how these vaccines would work against these variants because the studies were done, the randomized studies were done in the setting of the original Wuhan strain. And so when we started to see variants, we really didn't know how these vaccines were going to work, and all we had was vaccine effectiveness at that point. There were no more randomized controlled trials being done. Next slide. So we had a group that we put together starting in October of 2020. So that was before the first vaccine had come out. And several of you in the room were part of this effort with us here. And we felt that, to get started, we were expecting that there would be an explosion of vaccine effectiveness studies. And that turned out to be true. But we wanted to make sure that we would get out at least the sort of best methods that we could. And we knew that in high-income countries, they would probably be going their own way. They had large electronic databases. Some countries have full national databases of COVID disease and vaccination. So our target audience was really mostly LMICs who didn't have such resources at hand. And we really went back, I think, to the influenza vaccine effectiveness playbook. That was sort of the basis of what this guidance was, because the flu world has been doing VE studies for a long time. So the primary method we suggested in this initial guidance was the test negative design study, because we thought it was the easiest to do on top of particularly if you already had SARI or influenza surveillance in place. We've seen about half of the VE studies have been test negative design, and the other half have been cohort studies, so either retrospective or prospective. So it's interesting to hear that the 4 EMRO studies are 50-50. So it's sort of reflecting what we've seen in all VE studies. We had a list of criteria at the time. some of which have held up, some of which we've had to change. I give you the link at the bottom. You can go back, look at the original guidance. Next slide, please. So it wasn't long before we had to put out an addendum, and our first addendum came out in July of 2021 because we were starting then to see the first variants. Alpha and Delta had come in. We were getting lots of questions about how were these vaccines working in the setting of these new variants of concern. Well, as you all know, it takes time to do a VE study. It's not like you can get results within weeks of emergence. So we one of the things we did in this addendum is we put out some guidance on how to do a rapid method where you don't need case-based data. You could do it in population-based surveillance data called the screening method. That was used in a couple places, not very often. We also talked about a method called a case-only study, where you're just looking at people infected with SARS-CoV-2, some with the new variant, some with the original, and you're looking at the percent vaccinated. And that gives you some sense of how these vaccines are performing early on. One thing I'll remind you about is there weren't many lucky things that happened during COVID, but one of them was that it turned out that one of the most common PCR tests, called the TAC path PCR, had a feature where there were 3 targets, and one of them, the S gene target, there were mutations in some of the early variants, and there was something called S gene target failure in some of the variants, such as Alpha. And what that did is it allowed researchers to distinguish one variant from another without doing full genomic sequencing. So that happened with Alpha versus the original strain, and then Delta flipped back again to S gene non-target failure. It also allowed this distinguishing Omicron BA1 and BA2. So that allowed some early indication of what the VE was for these new variants. Next slide. And then we put out a second addendum. This came out last year, and things had really changed now. By October of 2022, Omicron had come on the scene, and Omicron, as you know, was a game changer in the sense that the infectivity was much higher, the severity seemed to be lower, and certainly it seemed to be evading vaccine-induced immunity much more. We also had waning VE by this time, and we were on to booster doses. So there was a lot more to talk about in terms of VE methods. I'm going to come back to some of these at in a few slides, because these are still relevant. We still, of course, are in the Omicron period, the later Omicron period, but a lot of these issues that we discussed in this addendum are still relevant. Next slide. One of the other activities we did here at WHO headquarters is that we were seeing VE studies that were disproportionately coming from high-income countries. And we realized that we wanted to see, the world needed to see VE studies from different parts of the world. So we held several VE stakeholder meetings that you participated in as well. And we tried to get a sense of where the studies were done and where the studies were being planned, and trying to kind of mix and match and even get some donors to participate in funding studies in parts of the world and for vaccines that we didn't have a whole lot of information on in these VE stakeholder meetings. And we still have these twice a year. We're actually planning one in January. Now it's just a chance for the different regions of the world to kind of touch base and compare notes on where they are with vaccine effectiveness studies, and also where they're going in the next year or two. Next slide, please. So this is, as of last week, shows you the pace of VE studies that were coming out either as preprints or as published papers. And at the top, you can see for the primary vaccine series, there's been over 400 VE studies. They peaked in 2022, but we're still seeing a smattering, some stragglers coming in that are looking at primary series. For the booster at the bottom, there's been over 200 studies. those peaked later in 2022 and early 2023. We still are seeing those come in. We're probably seeing about six to eight a week. Still not as many because there aren't as many VE studies happening now. Testing has stopped in many parts of the world, and care seeking has changed. It's gotten a lot more difficult to do these studies, but we still do see them coming in. And we still get lots of questions about how the vaccines are working against new subvariants, et cetera. Next slide. Now, Mernaz mentioned ViewHub, and I hope that everybody has looked at the ViewHub site. We partnered early on with Johns Hopkins School of Public Health because we knew that there would be so many VE studies and they needed to be organized and shown in a way that would be digestible for people. And so the ViewHub site has much of the VE information organized. On the left, you can see there's always a sort of an initial graphic that shows you for all the vaccines where VE studies have been done. My little red arrow indicates EMRO. This ViewHub site has neutralization plots, as you see on the upper right, and it has forest plots of all the VE studies broken down by vaccine type, by target group, by primary series, by booster, and these are always being updated. IVAC is doing a living systematic review, and every week the cumulative list of VE studies is updated and is sent out to people by my colleague Anshu Varma, and we're continuing to do that. So lots of VE resources from the whole world available at ViewHub. Next slide, please. Okay, so I'm going to shift gears a little bit for the second part of my talk, and I just want to talk about a few issues that I think are the most pressing issues we're seeing now in VE studies. Next slide, please. At the beginning of the next slide. Yep, that's it. So at the beginning, of course, in the VE studies, there was always a vaccinated group, and it was always being compared to an unvaccinated group. And that's the traditional comparator group, and it gives you what's called an absolute vaccine effectiveness. But in more recent times, we're seeing more and more, and I would say mostly what we're seeing now, is that a vaccinated group is being compared to another vaccinated group, and that other vaccinated group is a group that received vaccine in the past, and there's usually been some time since they've received that vaccine. And this gives you what's called a relative VE, and it's different, and it should be interpreted differently. And I think I like to sort of remind people that a relative VE is different, and you need to be careful in interpreting it. What it gives you essentially is the incremental or marginal VE on top of any residual protection that the other vaccinated group got. So if there's still some VE left, some protection left, then you're really getting the extra VE on top of that. Why are we seeing so many relative VE studies? Well, first of all, there are few unvaccinated people in many settings. At this point in the pandemic, and those who are unvaccinated tend to be an odd group. If you choose not to get vaccinated after being offered vaccine for 2 years, clearly you're a different type of person. You probably have different risk behaviors, different health-seeking behaviors, and so you can get a biased estimate. Next slide, please. This shows you the relationship between absolute VE and relative VE. At the top is the formula that relates the two. And what I want you to remember is that when you do a relative VE, essentially what you're doing is you're getting a comparison between two absolute VEs. Absolute VE for the newer vaccine and minus the absolute VE for the previous vaccine. And that's why you're getting this marginal increase. So by definition, your relative VE should always be less than your AVE, your absolute VE, except if you have no residual protection left, then it would be the same. If you get a negative V, if your RVE is higher than your AVE, then you need to look closely at why that is, because something is going on. hit the next slide, please. So this graph at the right shows you the relationship between AVE and RVE. I want to show you something here and demonstrate why relative VEs are tricky. Here is an example of, let's just say that your comparator group has 0% VE. So you've lost all your protection. This could be an example of VE against Omicron, against infection. You tend to wane very quickly and completely. Now you get that booster dose, second booster dose, let's say, and you go up to 50% absolute VE. And that puts you on this blue line, which gives you the relative VE, which also is 50%. You can see that in the top row of the table. Next. Now, here's another example. Let's just say you have a lot of VE remaining. So this could be, say, against very severe disease. And your VE from your vaccine 6 months ago is 90%. You get a booster and you go up to a VE of 90%. Well, that's only a 5% increase in your absolute VE, yet the relative VE is also 50%. So in both of these scenarios, you get an RVE of 50%, and you can see pretty obviously that RVE means a lot different things in terms of absolute VE. So you need to be careful in comparing relative VE in different settings where your comparator group is different. Next slide. And I just want to put this slide in to remind you, this is especially the case when you're looking at waning. This is one study from Canada where they actually did an absolute VE and a relative VE over time since the last dose. And you can see you would interpret waning very differently depending on if you were looking at absolute or relative VE. So we tend try not to look at relative VE for waning. It gives you some sense of the direction your VE is going, but I wouldn't interpret it in the same way I would interpret absolute VE in terms of waning. Next slide. Okay, the next topic I want to talk about is severe disease. Initially, in most studies, hospitalization was the definition of severe disease. But we have found with Omicron that has changed, and that hospitalization is no longer an adequate definition for severity with Omicron. And you can see that, hit return, please. If you look, could you go to the next slide? There you go. So if you look at the top here, these are studies that was looking at the primary series 6 months ago that just used hospitalization as the definition of severe disease. And you can see these dots are less than 50%, which is that vertical black line. In the middle are case definitions, which was hospitalization plus a requirement of some symptom or sign of COVID disease. And you can see the VE is higher here. And so what we think is happening, next slide, is that, oh, something's missing. Hit one more. There we go. So we think now when you have hospitalized COVID disease or somebody who's hospitalized with a positive SARS-CoV-2 test, there's 3 possibilities. One is that they could have severe COVID-19 disease. And that's what we saw initially almost all the time. But now we could see that maybe what they have is a SARS-CoV-2 infection that has exacerbated an underlying illness like congestive heart failure or COPD. And that exacerbation is what puts them in the hospital. Or they could have an incidental SARS-CoV-2 infection and be hospitalized for something completely unrelated. And so we think these 2 scenarios on the right are why we're seeing lower VE against hospitalization with Omicron, is we think we're picking up a lot of infection, and we know that the VE against infection with Omicron is lower. So what we suggest is that you always use some sort of respiratory symptom of COVID-19 in your case definition. And the more severe outcome you can use in your case definition, like an oxygen requirement or ICU admission, you're going to probably see a higher vaccine effectiveness. Next slide. And I'm almost done. The third issue I want to raise is infection-induced immunity. We know that seroprevalence now is high in most adult populations in the setting of Omicron, and that we're seeing multiple reinfections with Omicron because we know that there's waning against Omicron infection. What this means in terms of VE is a couple things. The first is that this issue of hybrid immunity, which is when somebody is both vaccinated and infected, so they have immunity from both, and they tend to have a higher VE. In the graph at the bottom in blue, you can see VE from hybrid immunity versus in red is VE from vaccination alone. And on the left is for hospital admission, severe disease. On the right is any infection. And you can see that hybrid immunity starts higher and tends to wane less than vaccine-induced immunity alone. Next slide. But things can go in the other direction too, so you have to be careful. You may have heard of this expression depletion of susceptibles. And what that is that in your comparator group, be they unvaccinated or less vaccinated, they're going to have less protection than your vaccinated group. So they may be infected more naturally. And that might mean that they have a more recent infection and they have more infection-induced immunity. And so what this can do, if you think about it, is that because your comparator is being protected by a natural infection, when you're comparing that with the vaccinated group, you're going to see less of a difference. And that will bring down your VE. You get a spuriously low VE due to this concept of depletion of susceptibles. And in some cases, it's even possible that your comparator group could be more protected than your vaccinated group because they've had a recent infection. Say you have a big wave of Omicron, well, you're going to get your comparator group infected a lot, and that's going to could result in a negative VE. So be careful in that setting. And I think that's my last slide. Go one more. Yes. So thank you very much.
Thank you, Daniel. Thank you so much. I mean, that was a great presentation. And also thank you for your all support during the process. I mean, supporting EMRO for this COVID-19 vaccine study. And we are really missing you in person here. So I think his presentation in particular, I mean, really facilitates the floor for discussion, because I think there were some parts that, of course, you may have some questions or feedback. So Daniel, please just be with us, because colleagues may have some questions regarding your presentation as well, okay?
Okay, thank you.
That's fine with you. Thank you so much. So now, I mean, we don't have any presentation for this session. Now the floor is open for discussion for 20 minutes, please. If you have any question, you can just, make your, name stand upright like this. And for colleagues who are online, please just raise your hands. And Malika, please just check the colleagues online. Savario, please.
Well, many thanks first for this very rich presentation. And I like very much the structure of the workshop by the fact that we start with challenges and limitation, just to trigger discussion. And that comes before the results presentation. So it's a very good, I think, way to proceed. I have to tell you that at the very beginning of the study, I was quite concerned, to tell you the truth, because of the timeline of the study and because of the different challenges you already anticipated, like the incidence of COVID-19, the variants, and many other aspects that we discussed several times with our counterpart in the Ministry of Health. I want to pick up on a few elements that were raised by Kamal and by Daniel that are quite relevant, I believe. So you rightly said that the immunization program at PHC level. So here there is a very big room for incorporation within those four circles of additional elements and additional key stakeholders, both within WHO, regional office and country office, as well as from the stakeholders that are on the outside side, Ministry of Health, research entities, and so on. Because, I mean, in terms of policies, when we come to the NITAG or other stakeholders, we need to think an overall approach. What is the incorporation of the PHC? And one additional element, building upon what was described by Daniel, specifically the relative vaccine effectiveness. These are very key components. Let's not forget about that. How do we convince, from a policy perspective, people to take an additional booster, especially in an environment like in Jordan now or many other countries where there is a lot of resistance? So one additional element in those four circles is risk communication, community engagement, especially when reintroducing a new vaccines. But also I think there are different elements to incorporate in these studies on how to complement the community perspectives within the effectiveness of vaccines and how to introduce and the policy orientation. So just a few elements from my side right now, because I have additional ones, because I think it was very rich, rich presentation that tackled different aspects. Thank you so much.
Thank you, Savarian. Dr. Nabal?
Thank you again. I also like the structure of the workshop so far. So my question is, in the current situations where some people get boosters, many they don't, in countries, for example, like ours and many other countries in the region where we do have multiple type of vaccines and people mixing up all type of vaccines all the time, what will be the ideal way to study the vaccine effectiveness, specifically the booster? I will not go to specific vaccine, but if you have multiple vaccines and you have different group who might or might not receive the vaccine, and if I want to go back, how far I can go back and start collecting the data, like 1 year, and see and check the effectiveness? And again, as I said, what is the best method we should use for vaccine effectiveness when it comes to booster? Thank you. I think I asked multiple questions at the same time.
That was great. Okay, so any other questions or comments from colleagues online? So yeah, please, Dr. Nabil.
Thank you for the fruitful presentations that we have today. But one important issue that was tackled by Dr. Kamal is the adverse effect following immunization. And we all know that COVID-19 in particular has a lot of adverse effects following immunization, especially because of the large number of the vaccines introduced in the all over the world. So do we have any study or any instructions in order to evaluate this issue?
Thank you so much. So let's see if there's any other colleagues have any question, or Malika online. So Savario, and then we can, yes, go to.
So I don't want to hijack, the questions session, but I believe one important aspect for all of us could be also the way forward in terms of documentation. Daniel showed a very nice slide where there was the pace of studies, and one of the aspects that they took into consideration was the published paper concerning different studies. Now, here I'm not telling about publication for the sake of publication. There are so many experiences in the region, and I'm a big advocate of documentation with peer reviews, especially, because these are very helpful, especially in anticipating possible challenges that you listed. So we need to do that, especially for the limitation that can be helpful for, next experiences in the future. Over.
So yes, so now we have, two questions. So one of them from Dr. Nabal, I think, Daniel, and then Manuela, you or Carsten, you can, address this question. So Daniel, do you remember Dr. Nabal's question? Regarding, different vaccines and different types of vaccines and also boosters, and
Yes.
now what's the best method to do the vaccine effectiveness studies? Thank you.
Yes. That was a good question, and there was a lot there to bring out. I had a couple thoughts listening. One was that there early on were some studies that looked at heterologous series, so people who got different vaccines, either for the first and second dose of the primary series, or they got primary series followed by a different vaccine for the booster dose. And in general, it was shown that heterologous schedules were as good, if not better, than getting homologous, the same dose. I think what we're seeing with boosters is that, particularly with boosters, people are getting a different vaccine than they got for the primary series, and that much of the booster doses that are being given are mRNA, and maybe the primary series was an adenovector or inactivated. I think ideally, if you have all the data, you can sort of look at different combinations. So this vaccine is primary series and this vaccine is a booster, what's the VE? But honestly, I think what we're seeing is that when you get a booster, particularly with an mRNA vaccine, it kind of levels the playing field. So it's less important what you got for the primary series. So I know it becomes difficult from a data collection standpoint to know exactly every dose that somebody got. And then if you're putting them in different categories, you're getting few numbers, you're not going to have enough power. So I would say from a practical standpoint, you don't have to worry quite as much about what they got for the primary series. You could just look at first booster dose, second booster dose, etc., and just lump everybody together, regardless of the primary series. I think the second part of your question was how far back to go. And that's particularly an issue with a relative VE study when your comparator group has been vaccinated. So for example, if you want to compare the second booster dose to the first booster dose, your comparator group will have received the first booster dose. Many sites use 6 months as a cutoff. So you had to have that first booster dose 6 months ago. I think it depends on what your outcome is. Because if you're looking at infection, we know that infection against Omicron wanes quickly. So if you go back 6 months, you're probably going to have little VE left from that first booster dose. But if you're looking at severe disease, we know that protection against severe disease is more durable. And that's probably in part due to cellular immunity. It's probably in part due to a memory response, so that even though you may not see antibodies around, when there's an infection with SARS-CoV-2, it activates memory B cells, and you get this big rush of antibodies that are formed, protecting you against severe disease. So I think what I'm saying is that it probably you have more retained VE for severe disease, and that's where I mentioned you need to be careful in comparing different groups that go back different points in time. But I'd say 6 months is something we see a lot as sort of how far back to go back in your comparator group. I hope that answered your question. If not, please let me know.
Thank you, Daniel. So anything else, Manuela, or Carsten, or Thomas, that you want to add to this question? Or I mean, to the answer to this question? Okay, no. So let's just, Kamal answers Dr. Nab's question, and then we will have another question from Dr. Rashid. Please, Kamal.
I would like to start with Saveri. Thank you very much for raising this issue of integration, which is coming now high in the global agenda, how we would integrate immunization to other PHC program. Actually, Saveri, it's a win-win situation that everybody in the Ministry of Health working on the primary healthcare should be understanding that leveraging the success from immunization would help in the integration process. So this is a policy decision to be taken to get the benefit from the immunization program for the success of primary healthcare, as well as the success of other healthcare program in the primary healthcare for the immunization. So this is a mutual perspective. But when it comes to the other portion of your question in relation to the community is completely something else. Because when it comes to a decision coming from the Ministry of Health to introduce the vaccine or to get an integration of primary health care with immunization, we should be understanding that our client is the community. So we should be mobilizing the community. That's why we have the RCCE component in order to mobilize the community to get this kind of benefit from this integration or specifically from this vaccine. So this is, and I think in most of the ministry, there is a specific entity for doing that, helping in the success of this integration or in the introduction of new vaccines. When it comes to the question of Dr. Zainab, this is a very important question, because I can see here that the decision maker in any country would be in a state of a bit of confusion. If I have a high vaccine effectiveness vaccine that has to be introduced, how would I weight it in balance of the AFI, knowing that the AFI, the adverse effect following immunization, is something that it is cross-cutting for every medication, not only the vaccine, even the medication. But we have to weigh these AFI in response to the benefit. And here I would ask Dr. Azzuddin if he is still with us, because from the strategic perspective at looking as the advisory side, how we can weigh the balance between the effectiveness, the benefit of having vaccine versus the presence also of some adverse effect following this immunization, and how to convince the community to get the vaccine in spite that they know preemptively that there would be some adverse effect following this immunization. Dr. Azzuddin, are you with us?
Yes, I am. Actually, the question, Kamel, was mostly about the number, and she rightly said that we might have big numbers because of the huge number of doses as well used. So this is expected, and as you said, actually, whenever, I mean, we have, you know, if we have a good surveillance system of AFI, I mean, the objective is also to compare the incidence of AFI cases to what is actually expected. So as long as we are not, exceeding what is really expected, this is something that is acceptable. So I think how to convince, we have to explain to the population this issue. They have to know that we are not talking about number, and the number is high, it's true. And we see this usually in the campaigns. Even if you remember, whenever we have catch-up campaigns or we have school vaccination, sometimes with a huge number of people vaccinated, sometimes we have a big number of it's expected. So it's a rate that will, so definitely. So the issue is how can we explain, and we need to tell the population since the beginning, perhaps, that I mean, it's not something that is not unusual. This is expected, and this is including the weight and balance between the desirable effect and desirable effect. So I think this is the only way, and we are dealing with this with other vaccines. So again, we perhaps back to what Danny was saying. I mean, we should really pay attention on what are we saying. We are talking about numbers and not incidence. So and we have to include this in what is expected and what is not expected. And the base is to have a strong surveillance system of AFI to be able really to use this information and to decide to how to say, to engage the population to take the vaccine and to solve this issue. Thank you.
So I might take the opportunity of the experience of Dr. Azzuddin in raising this important point related to AFI. So Dr. Azzuddin, do you think that it is still advisable that, knowing that the AFI is very little, very, very little, is it advisable to inform the community while we are delivering the vaccine that there might be a very small probability of developing this AFI, being honest to the community so that we can gain their trust? Or do you think that there is no need to elaborate on that to the community, knowing that there may be some kind of vaccine hesitancy that will come after, or refusal, especially toward these new vaccines?
I mean, from my experience and from I think what is mostly recommended is to be frank with the population. So it's to be proactive than reactive. So it's much better to be proactive and to explain very well that we are expecting, you know, sometimes someone who go just across the streets, there is also a risk. So risk is always there. So I think we have to be frank since the starting. And I'm not talking about perhaps COVID, but I'm talking generally about all the vaccines. What we recommend is to be transparent with the population, and but to be also to justify and to come with some I would say positive advantage and disadvantage. I mean, we know that, for example, this vaccine will reduce by 90% the disease, but also we might have 1 per million, etc. I think usually is, and what we advise actually people to do is to be transparent and act proactive rather than reactive. Thank you.
Thank you so much, Dr. Rashid. Please.
Thank you. I would like to thank you for the three presentations, Dr. Mehernas, Dr. Kamal, and Dr. Daniel. It was very rich and very instructive. I find something that we were like challenges that we was exposed in Morocco when we conducted the tree study. The first one was a retrospective study, and the second was a negative test negative study, and the third one is ongoing. It's a screening method. So we was exposed to some difficulties, but we was lucky to have some things that we facilitate our work, like when the subject is a strategic problem like the study, we have everything. We could do the study with the support of local administrative. And the second one we have in Morocco a local committee, ethical committee that is recognized by the FDA, so it make the work so easy. I have not really a question, but some proposition, like how WHO can support Morocco in policy, in capacity building on policy brief. We have a lot of problem of this. And the second one, what's the place, and what can some kind of study like meta-analysis? We have now a lot of study of effectiveness. So how can meta-analysis or review, systematic review or umbrella review can make data for policy? Thank you.
Thank you so much, Dr. Rashid. First of all, thank you for sharing with us, those information about the three studies in Morocco. And I think that, in the tomorrow's session that you will discuss and, giving us more information about these studies. So we are really looking forward to just hear those from you. I mean, this is a bit different discussion from our discussion about policy briefs and data from meta-analysis. I just want to tell you that Morocco is one of the priority countries for evidence-informed policy making for us. I mean, the work has started since 2021, I can say, with Morocco regarding enhancing the capacity for using evidence for policy making. And in that case, we had several trainings and also joint development of some policy briefs and some policy documents, and also some other types of research studies. I think during the break I can talk with you to see how we can also engage your institution in our network, and also we can discuss this more with country office, that how we can support you more. But there are many things happening, I mean, with Morocco now. So let's discuss this during the break time. So Dr. Fatima.
Thank you. Thank you, Dr. Daniel, for your interesting presentations. I think you brought into discussion points that we have seen in our results regarding the low VE and the relative VE, as well as the negative results. My question is how to use this result in a country like Jordan, that we have maybe the only COVID-19 effectiveness study, and how to use this result to convince policymakers policy making, seeing the low VE, and I will present the Jordan experience in that, and you will see. So this is my first question. The other question is maybe raised by Saverio, because we are facing nowadays resistance and hesitancy for vaccines from the community, for very well-known effective vaccines incorporated in the EPI program. So what to do and how to convince the community also to take boosters if this is the recommendations. Thank you.
Thank you, Dr. Nebat. But, I just want to mention that, in the session that we will have Jordan and Iran presentation. So after that, we'll have a discussion to discuss in details any specific questions regarding the countries. I mean, kind of these challenges that you have. But, Daniel, if, in just 1-2 minutes, if you can answer or just guide for this question, would be great. Thank you.
Oh, okay. Well, without going into specifics of your study, which we'll hear about tomorrow, I think there's a couple things that I feel like I've learned in looking at so many VE studies during the pandemic. One is that it's hard to make a conclusion or make a decision based on one study. And I've seen one study come out and people get very excited about it, and they it might have a low VE or a high VE, and they immediately are jumping to sort of changing policy based on the one study. But as I talked about a little bit, there's so many potential biases in each study, and you really need to understand what goes into the study in terms of case definition, all of the factors to understand and interpret the results. So that's why, for me, I like those forest plots that you can find on ViewHub, because it shows you all the results, and what you see is a range of results. And I think when you look at it all together, the story starts to make more sense. You sort of see where the median is and sort of what the general trend is. So, that may not help you so much in Jordan, in one country, because there is a lot of emphasis on a study from your own country. But I do think one approach, obviously, would be to put it in the context of all the other VE studies that have been done, both in the region, but also in the world. We don't, honestly, we haven't seen that these vaccines behave very differently in different parts of the world. They tend to have similar effectiveness. So if your results are out of line with what is being found elsewhere, I think you need to sort of question a little bit sort of why you're seeing those results in your setting, because it would be very unusual to say, oh, this vaccine doesn't work in this population, but it works everywhere else. So I guess that would be a general advice to you in sort of communicating the results, is sort of course, give your results, but then put it in the larger context of what's being seen elsewhere for similar populations and similar vaccines.
Thank you, Daniel. So we will just get 2 questions from Dr. Najafi, and then Dr. Les, the last 2 questions, because now is also the time for coffee break, and we really want to be on time and just follow the time schedule that we have. So Dr. Najafi, then Dr. Les.
Yes, thank you. Thank you for all presentation. Probably I can postpone the question for the discussion after my presentation, but very briefly, I want to make this point regarding the presentation by Daniel, regarding the challenges that we have in methodological terms for vaccine effectiveness study. Actually, when I started my project, I didn't realize that I faced with too many challenges in terms of methodological, running the project. But one issue that I would like to discuss here is just
past history of COVID-19 or natural immunity for those cases or control in a nested in a test negative case control study. So as all of us know that for COVID-19, it's very difficult to find who is infected and who is not infected, because not all people with a sign and symptom can just give the RT-PCR. So it's very difficult to adjust for previous history of COVID-19 infection. And I understand that, not adjustment for such confounding factor just decrease the vaccine effectiveness in overall terms. But Daniel, do you know how we can just, address this point in our study?
I think what you raised is a huge challenge now, is that infection is so widespread. And as I mentioned, if you're less vaccinated, you tend to get infected more, and that's going to give you more infection-induced immunity, which will bring down your VE. I think as you point out, early on, people were able to limit their analysis to those who had not been vaccinated. So if you had prior infection, you were excluded. That's very hard to do nowadays, because so many people are infected, and then as you point out, they're not tested. So even if they say they haven't been positive, they may have been infected. So it's a real challenge. One thing I would suggest, and that we've tried to start to do, is you need to interpret how these vaccines are working. It's not just looking at the VE study. I think you have to put the VE study together with the epidemiology. So you have to look at your population in your country and see what's happening. If you do a VE study and you show a very low VE, but then you look at your population in a vaccinated group, say the elderly, and you're not seeing a big spike in cases, despite circulation of the virus, or you're not seeing a lot of severe cases, that suggests that there's some disconnect, that that maybe the vaccines are actually still working. Because if they were completely failing, you would likely see something more similar to what you saw at the beginning, with these huge peaks in cases and hospitalization. So I think that's one good approach, is when you're presenting your VE studies, also present the concurrent epidemiology in your country, and try to put the two together to help interpret what's happening.
Yeah, thank you. Just question, you mentioned regional IRB clearance. So I was actually very curious, how did this work and why it was needed, in fact, and just to see how we can benefit from it in the future.
So the regional ethical clearance, we have regional research ethics review committee here, but this is for the studies that WHO initiated, or for example has a collaboration with them, not for national. For example, if your institution or another institution has any kind of studies, we don't just get this clearance. But when there is any kind of studies that WHO is doing that, or for example is collaborating to that study, we absolutely need to have this regional ethical clearance.
So at no point you used it for countries that do not have actually their own, let's say, institutional IRB committee. This wasn't used as the IRB of record for this? No, never. Okay. Because sometimes, we do have reliance agreements for IRB. Some institutions, they may not have their own IRB committee. Mm-hmm. So we use actually an IRB committee for different institution as a replacement. So I was curious whether this was the role of the regional, but apparently not.
As far as I know, we don't do this, but if you have any
No, thanks for raising this. It's a very important because we had some misunderstanding during the previous, studies, the seroprevalence as well as the case control of infections in different hospitals. So from WHO perspective, whatever we promote as WHO studies, they need to go through the regional, but these should be also further confirmed through the national ERB. So this does not replace any national, but both of them, if something done in collaboration with WHO.
But your question was, if there is no committee to just, you can receive national ethical clearance, if you can replace it with, WHO ethical clearance, I don't think so that we do it. I mean, we just do this for the ones that, yes, exactly.
No, but this can help. So if there's a committee approval at the regional level, then we take it to the national level or institution level. And we tell them that it has been already reviewed at the regional level and they are okay with it. So it helps.
Oh, sorry, it was facilitates the process for national ethical clearance. So I think that we can stop here. With your permission, I want just to reduce a bit time for coffee break from 30 minutes to about 16 minutes. I mean, if you can be here at 11:35, so at least we will be just 5 minutes behind the schedule. Is it okay? So please, coffee break is ready. You can just, go through this door back here. And then, at 11:35, we will be here for the rest of the sessions. Thank you so much. Thank you.
Okay, so thank you very much. My name is Francisco Nogareda. I'm working in the special program for comprehensive immunization department at the Pan American Health Organization, which is the regional office for the Americas. I'm the focal point for seasonal influenza vaccination, but I also coordinator of the regional network for vaccine effectiveness in the American region. I'm going to present the American experience in terms of monitoring and evaluating the vaccine effectiveness, and just presenting briefly what we. So we have two lines of work. The first one is the evaluation of vaccine effectiveness for COVID-19 vaccines using the Sentinel Surveillance Network in the region. So this is a network called REVELAC. And the second line is the estimation of VE using specific research studies. I will focus on the first line, which is the evaluation through the Sentinel Surveillance, Sentinel Surveillance Network. Okay, so just a bit of background. This network, the REVELAC network, is the regional network for vaccine effectiveness evaluation in the American region, was established 10 years ago in 2013 and leverages the existing SARI Sentinel surveillance system already in place in countries. The main purpose is to generate annual VE estimates for seasonal influenza vaccines in the Southern Hemisphere. However, since September 2021, COVID-19 was also integrated in this network to also estimate the VE for these vaccines. In 2023, 5 countries in the Southern Hemisphere participated in the evaluation with more than 486 hospitals participating. The 5 countries are Argentina, Brazil, Chile, Paraguay, and Uruguay. You can see in the map on orange. It's an intersectoral network in terms of we at regional office, we work with Ministry of Health of the countries, with country office of WHO in the region, but also with partners like CDC, US CDC, and interinstitutional network. As I mentioned, we work with laboratory, surveillance, and immunizations departments. So the main objectives of this network is to estimate the vaccine effectiveness for COVID-19 and also influenza in preventing SARI among patients with laboratory confirmed infections. We obtain specific VE by type of vaccines, number of doses, age groups or priority groups, and by genomic variant for SARS-CoV-2 or type or subtype for influenza. Sorry, we have a specific protocol. This is a generic protocol. It's available on the website. And this protocol has been adapted to the country-specific characteristics. So we used a case control test negative design. The study population is the SARI patients admitted in the participating hospitals. And we're using the WHO SARI case definition, standard case definition, which is the same for influenza and COVID. And on the right-hand side, you can see that the flow chart or something that you can see that any SARI patient admitted in the participating hospitals is tested by PCR. If it's positive for COVID, it's considered a case. If it's negative for COVID, is classified as a control. And for both cases and controls, we obtain or we collect information, including the vaccination status for COVID. So we classify them as vaccinated or unvaccinated. And we estimate the vaccine effectiveness using this formula 1 minus odds ratio multiplied by 100. So we requested countries, they are participating to report at least these core variables in terms of patient, country, hospital, age, sex, and pre-existing conditions, clinical and laboratory information in terms of onset of symptoms, admission date, date of specimen collection and result by PCR, and the vaccination status. If it has been vaccinated for COVID and for influenza, as I mentioned, we jointly conduct VE for flu and for COVID using the same network, yeah? And type of vaccines, date of vaccination, and the source of vaccination. This is the minimum, but of course there are more variables that we collect. But with these minimum variables, we can obtain the vaccine effectiveness. Data is reported through this online surveillance system, reporting system. This is it's called PAHO flu, and countries, they are reporting case by case all this information through this online system. In terms of ethical review, we submitted this protocol to the PAHO Ethical Review Committee at WHO Regional Office. And since this is our observational study, part of the routine M&E activities of the vaccination program, the PAHO ERC determined that it does not constitute research with human subjects, and therefore there is no requirement for PAHO review. So this is important because it's not considered as a research study per se. It's considered as part of evaluation of the programs of the surveillance and the preventive measures, specifically for vaccination. However, countries can submit the protocols to the national committees for their approval, and in any case, we ensure confidentiality and privacy of individuals. Just briefly, I'm going to share you some of the results we obtained. We're not gonna go into much detail, but I want to show you what we obtained. So this table shows the number of vaccines used in these countries that participated. As you can see, there are 10 different vaccines used by these countries. Chile used 7 vaccines, Paraguay 8 different vaccines. I just want to highlight the number of vaccines makes this evaluation more difficult, because when we stratify by type of vaccine, we're losing population. So our estimates are less precise. We try to also combine them by type of vaccine. Like viral vector vaccine, inactivated virus vaccines, and mRNA vaccines. So we combined them and we had more power in our estimates. Okay, this is the flowchart. We initially started with more than 16,000 patients for a period from February 2021 to September 2022, but we excluded more than 4,800 patients because of different exclusion and inclusion criteria. So our final sample size was more than 11,500 patients. Since we wanted to have estimates by variant for COVID-19, we split the sample size in 3 different periods. The pre-Delta period, where there was a co-circulation of different variants, we couldn't really have variant-specific vaccine effectiveness because there were many variants circulating. And then we had the Delta period. Most of 100% of the cases were Delta variants, and then the Omicron period. So we obtained VE for each of the periods. And then from each of the periods, we obtained the unvaccinated, vaccinated with 1 dose, completed primary series, and booster. If you look at on the pre-Delta period, you see there are a lot of unvaccinated people. And then we have 1,000 partially vaccinated because the rollout of the vaccine was in the beginning. So we didn't have many completed vaccination for primary series. And you see booster, there is none in the pre-Delta. But if you go to Omicron period, you see that we have less unvaccinated and more with booster. So you see the rollout was evolving from the pre-Delta, which is initial, from February to July 2021, and from Omicron onwards, which is from December 2021 to September 2022. So this is one of the results. We obtain results by age group, by type of vaccine. On the right side, you can see AstraZeneca, Sputnik, Sinovac, Sinopharm, Covaxin, and Pfizer. And for Delta and Omicron periods, you can see roughly the VE decreased from Delta to Omicron for all vaccines in both age groups. This is what we obtained. The good thing is that we obtain estimates for non-widely used vaccines like Covaxin, Sinopharm, Sinovac, and Sputnik. Same as in the EMRO region, that you have different vaccines that does not really have evidence of the vaccine effectiveness. We also study the vaccine effectiveness since time of last dose. So we see for viral vector vaccines, people vaccinated within 90 days, the vaccine effectiveness was 72.2 and decreased to 39.4 when it's vaccinated between 3 months and 6 months, and decreased to 12.5 when the last dose was given more than 6 months. And the same thing with the mRNA vaccines. We observed this waning protection that has been reported widely. That also helped us to justify the introduction of booster. So we are talking about using the evidence into policy. So we use this information to help countries to support the justification and the introduction of the booster dose, since we observed this waning protection for primary doses. And I want to also show you the results for influenza, since this network produces also vaccine effectiveness for influenza. This is data up to July 2023 in the Southern Hemisphere. You know, we have different, the time for the season, influenza season starts in March, ends in October. This is a mid-season estimates. We had a predominant H1N1 type influenza virus, and the peak was at the end of May, beginning of June. These are the results with the participating countries. These are the estimates. So we produce these estimates. We report these estimates to the WHO for contributing to the vaccine composition for the next season. So these results are shared every season annually to the WHO composition meeting to determine the best or optimal composition for seasonal vaccine, seasonal influenza vaccine. And again, these are the results. We obtain higher VE in children compared to patients with comorbidities and elderly. We can see that in all type of influenza, any type of influenza, influenza A or influenza A H1N1. Since we have limited circulation of influenza B, we only had a really rough estimate for VE for all age groups. So just last slide, these are the main challenges in terms of COVID-19 is a complex vaccination landscape. Many vaccines approved and used in different countries. We had small sample size for some of these vaccines. There were donations, and so they were, used very limited. So we don't have really enough power to really have estimations for these vaccines. Another challenge was to match the vaccination registries and laboratory results with the surveillance collected at hospital level. Luckily, some of the countries introduced electronic registries for COVID, but it is not the case for all countries. And it was difficult to match these different sources. There was also difficult to recruit controls, negative patients for COVID during high incidence periods. So we had most of the patients admitted in the hospitals were positive cases. So we didn't have enough controls to compare. And in Omicron period, we have high vaccination coverage in the countries, 90%, 95%. So we had a problem with the comparison group, with the unvaccinated group. They are not representative of the source population. We couldn't compare these unvaccinated since they are not, they are not longer representative of the population. They have specific behaviors that could introduce some bias. This is the website, is on the PAHO website for the REVELAC. You can check, there are information about the vaccine, the evaluations we do, these regular updates with the estimations. And these are some of the articles we published. This is the paper that we just published a few days ago in the Lancet. This is for COVID-19. And these are for influenza. We do it regularly every season. And this is the network. We celebrate the 10 years anniversary this year, this in May in Guatemala. And these are countries participating, and we gather there and we discuss all these results and how to move forward. So that's it. Thank you very much.
Thank you so much, Francisco. I mean, I was just, talking with Kamal that how much is, your experience and your challenges is similar to what also we faced during this, regional study here in EMRO. But of course, you may have some questions from Francisco from, PAHO experience. But as you see in the agenda, we will have a section for discussion. So within that session, we will go through any questions from the presentations. So now we want to just move to the next presentations by Dr. Farid Najafi, Professor of Epidemiology, Kermanshah University of Medical Sciences in Iran. Thank you.
Good afternoon. Let me start with the title of the presentation. So this is the project that we have run in Iran for assessment the vaccine effectiveness, COVID-19 vaccine effectiveness. And we did it in 8 universities. So just very brief about the situation of COVID-19 in Iran. So far, the total number of confirmed cases till October 25th, 2023 is something around 8 million. So first vaccine was administered in 9th of February 2021, meaning that 11 months after the first COVID-19 in Iran. So we administered the vaccine very late. And I want to remind you about the effectiveness of vaccine after 11 months of administration, 11 months of first COVID. So the proportion of people with complete primary vaccination is something around 67% now, and proportion of people with booster vaccination is 34%. And the policy for those periods was just administration of vaccine for people age 12 and above that. And if you look at this graph, so this is the first vaccination in Iran. So before first vaccination, we had 3 big waves of, COVID-19 in Iran. And this is the time period for all sample size, for sample recruitment. And this is the Delta period and Omicron period. So we try to include patients from Delta dominant circulation and Omicron dominant circulation in our study. So the different type of vaccine that we have now in Iran, as you can see, 5 locally produced vaccine, Nura vaccine, and ROS vaccine, ROS-Pars, Spikogen, and Coviran Barakat, Fakhra Razi. So all these are locally produced vaccine, plus some vaccine from Cuba, Soberna vaccine, and Sputnik from Russia, and AstraZeneca from UK, and even from India, Covaxin from India. And the most commonly used vaccine in Iran was Sinopharm or Covilio from China. So just look at the objective, very brief. The first objective of our study was to estimate the vaccine effectiveness against the hospitalization by type of vaccine, demographic variables, and by period of variant circulation. And the second objective was to estimate the vaccine effectiveness to reduce the chance of severe outcome defined by ICU admission and or deaths in our study. So what was the definition of the vaccination? We classified the people who receive or not receive the vaccine to 4 groups: unvaccinated, meaning a SARI patient, unvaccinated if they didn't receive any COVID vaccine or receive it within 14 days before current hospital admission. And vaccination with 1 dose, again, individual partially vaccinated if they have received 1 dose of COVID-19 vaccine more than 14 days before the current hospitalization, and the same for fully vaccinated and booster vaccination. Just for booster vaccination, we use the time period of 7 days. So the outcome of interest for our study was first hospital admission. So at least 24-hour hospital admission with SARI symptom, and the severe outcome, meaning the hospital admission to ICU or died within hospital. So overview of the study, a test negative case control study using registered data. So we didn't collect the data within the hospital. We just used the registered data. 8 university or provinces participated in our study. The time window for selecting cases and control was 30th April 2021 till 20th of June 2022. And the primary sample size was intended to be 30,000, something around 30,000, but we didn't, we couldn't complete the sample size. So just something around 20,000 patient. 2 data sets, we used 2 data sets. Medical Care Monitoring Center data. These include all the clinical information about the patient admitted with SARI symptom and the electronic health record data called SIB in Persian language, containing all the vaccination history of the Iranian people. So diagnosis of COVID-19 was based on RT-PCR. So in each university and in each province, there are some confirmed lab to do the RT-PCR. So we collected the data from those labs. And this is just a selection of cases and control. So we excluded some cases and control because of not meeting the inclusion criteria. Actually, we match cases and control based on hospital type and the date of admission. So the original sample was intended to be something around 30,000, but the analysis was done on 216 for cases and for control, for control, and 6,098 for cases. So I'm not going to describe in more detail for data management, but we had 2 teams, one in each university, collecting the data, linking the data from hospital to vaccination data, and then try to just find those with invalid value, and then sending to central team. And central team again did the same thing, cleaning the data and invalid value for some variables. And then we send it to a regional office for entering the data to REDCap. And we calculated the vaccine effectiveness by using the vaccine effectiveness equal 1 minus odds ratio multiplied by 100. And we calculated confidence interval as well for 2 outcomes, hospital admission and severe outcome. So this is just description of the some variables in our study in terms of age group, sex, and how many of patients admitted to ICU. So something around 20% of patients have been admitted to ICU. The proportion of deaths in our sample was just something around 5%. And the number of the comorbidity that patient have, so 0, 1, and more than 2, meaning that patient have no comorbidity, and patient with 1 or more than 2 comorbidities. Time for hospital stay and oxygen saturation on admission. We recorded the oxygen saturation on admission, and the age group you can see from 12 years old until for people older than 65. So just some results. This is again, this graph shows the number of people who have been partially vaccinated, fully vaccinated, and booster vaccination, with showing the homologous and heterologous vaccination for fully vaccinated and for booster vaccination. So you can see the number of people here, unvaccinated, partially vaccinated, and fully vaccinated. So if you look at the proportion for fully vaccinated is just 14%. So it's tiny proportion of people receive the booster vaccination. And for fully vaccinated, among the control is 17%. and for cases is just 13%. And again, vaccine can be a combination because we had too many vaccines. So we classify the full vaccination and booster vaccination as homologous and heterologous. So this is the vaccine, the result of for vaccine effectiveness against hospital admission, classified by the variant of dominancy. So Delta variant and Omicron variant. And as you can see, the effectiveness, the point estimate for effectiveness for Delta variant is greater than Omicron, but there are too much overlap between the confidence interval, meaning that actually we can't say that the vaccine effectiveness is different from for these two variants. And this one shows the vaccine effectiveness against hospital admission regardless of the dominant variant of circulation. So we just calculate it as a total, and you can see the point estimate is 22 for adjusted vaccine effectiveness, 35 for fully vaccinated, and 33 for booster vaccination. Again, confidence interval have too much overlap. And this is the vaccine effectiveness against severe outcome, meaning ICU admission and or deaths. Again, the effectiveness for Delta variant is higher than Omicron variant, but we have too much overlap between the confidence interval again. And this was and this is the result of vaccine effectiveness regardless the dominant variant of circulation. So again, adjusted vaccine effectiveness for partially vaccinated is 33%, 34% for fully vaccinated, and 20% for booster vaccination. So some interpretation and limitation of vaccine effectiveness estimate. So lower vaccine effectiveness against hospital admission and severe outcome during the period of Omicron circulation is consistent with the finding from other studies. And actually, we observed such finding in our study. And the effectiveness of vaccine against hospital admission and severe outcome are decreasing with age. I didn't present the effectiveness by age group, but I have it in the annex. If you have enough time, I can show it, which is consistent again with the other findings. And the administration of booster dose is associated with increased effectiveness of vaccine against hospital admission, and the effectiveness of vaccine against severe outcome decrease when compared to their effectiveness against hospital admission. So it's very interesting to see that. And some limitation. The first one, no trend on oxygen saturation and trajectory of other risk factors in our data, because it's just registered data and it's just real life, and we didn't have all the trend for such variables. The presence of measurement error is crucial in our study for both exposure vaccine and classification of cases and control. I'm saying the vaccine because in some period of time during the, recording the vaccine status of people, just healthcare worker recorded the vaccine status on the paper and then enter it to the national data. So it's quite possible to have some problem when entering the data to the national data. And regarding the, case and control, again, we have some misclassification because, as I said, as a question from Daniel, it's very difficult to actually differentiate between the real cases and real controls. So again, in our case control study, the number of the cases is 2 times of controls, and this decreases the power of the study. It's not unusual for infectious disease study, but it decreased the power of study. And low coverage of vaccination in our sample didn't allow us to calculate the vaccine effectiveness by province, by even vaccine types. some vaccine types. So last slide. The overall effectiveness of vaccine used in Iran was estimated to be less than optimal, partly due to type of vaccine use and classification error inherent in the test negative case control study conducted using the register data. And the other reason probably is just, having too many people that have natural immunity. So comparing the people with vaccine with those with natural immunity but without vaccine decrease the calculated effectiveness. So, and as a conclusion, the progressive evolution of the virus necessitates the generation of the new vaccine to be used for future waves of epidemic. And that's it. Thank you.
Thank you so much, Dr. Najafi. So this was the presentation from Iran case study. So we have another presentation. So for the questions, we will have after all. So we will have another presentation from Jordan, again, using the same method, which was a test negative design. And Dr. Fatima will present the presentation.
Thank you. So I'll present Jordan CVE using the test negative design. So at the time of CVE study started in Jordan, the weekly incidence of COVID-19 was around 3.7 per 100,000 population, with a death rate less than 1 per 100,000 population. And the hospital occupancy rate at that time was less than 1% in period of Omicron predominance. So following the introduction of COVID-19 vaccine, Jordan has implemented a phase distribution plan, prioritizing those at a higher risk of complication and high risk of exposure and transmission. A few months later, we expanded the target population to the age above 12 years. 4 different types of vaccines were provided: Pfizer, Sinopharm, AstraZeneca, and Sputnik. Booster dose has been given first to some citizens and residents for the purpose of traveling and for healthcare workers, and also for those at high risk of complication. And late in 2022, we included the age of 5 to 11 years to the vaccine target population. So regarding the SARI surveillance system in Jordan, Jordan has built its national capacities and had well-established SARI surveillance in the country, using at 4 sentinel sites representing the 3 regions of the country. And we use the 2014 WHO SARI case definition. With the emergence of SARS-CoV-2 and COVID-19, we included the system has included the SARS-CoV-2 testing in 2020. So our primary objectives, we aim to estimate the overall CVE in SARI patient belonging to the COVID-19 vaccine target population. Our secondary objectives were to estimate the CVE by vaccination status, to estimate CVE for more severe outcomes, and to compare CVE for different age groups, kind of vaccines, and time since vaccination. So the CVE was based on a test negative case control design. I'm not going into the principle of this design because it is already mentioned by colleagues. The study population, we included the SARI patient in a hospital that is part of the SARI surveillance network and belonging to the COVID-19 vaccine target population in a period of 12 months from June 2022 to June 2023. The sample size was calculated based on WHO sample size calculator and was estimated to be 900 for cases and 1,800 for controls. So we included the SARI patient in the CVE study when they meet the inclusion-exclusion criteria, and they're well defined and trained healthcare professionals were electronically collecting data using WHO case investigation form from different sources, and respiratory samples were routinely collected through the SARI surveillance and tested for SARS-CoV-2 by real-time PCR. We had 1,874 cases. We excluded one because he did not consent, and we had 224 cases and 1,649 controls. For the data cleaning, validation, and verification, it was carried out locally by a monitoring team in coordination with the SARI focal points coordinators, and it was also supported regionally by WHO EMRO. So cases and controls were first described by baseline characteristics. The measure of association was odds ratio measured by logistic regression, and the CVE was computed as the known formula. Univariable and multivariable, multi-level logistic regression analysis also was carried out, and stratified analysis was conducted to better understand the effect of modifiers and confounding. So our results. The median age was 56 years. Cases were older than controls, and almost 49% of cases and 34% of controls were aged 65 years and above. Both sexes did not differ between cases and controls. 77% of the study sample had at least one chronic condition, and more cases had at least one chronic condition than controls. The largest population were admitted to King Abdullah University hospitals in the north, followed by Karak Hospital in the southern region of the country. In terms of vaccination status, the vaccination status did not differ between cases and controls. 46% and 51% of cases and controls respectively received Pfizer, followed by Sinopharm. 41% of cases and 45% of controls had a period of 12 to 18 month duration since the last vaccine dose. More cases were admitted to ICU, and also more cases had a higher hospital-based mortality than controls. So in the initial crude analysis, we found that the VE in comparison to unvaccinated, fully vaccinated demonstrated a VE of 7%. And after adjusting for several factors, the VE estimates ranged from 4% to 23%. However, none of these results were statistically significant because of the wide confidence intervals. In the crude analysis of the VE by vaccination status, we found that the VE in comparison to unvaccinated individual, fully and partially vaccinated, demonstrated a VE of 7% and 23%. But the wide confidence interval persisted. In the comprehensive multivariable analysis, where we adjusted for several factors, fully booster and partially vaccinated in comparison to unvaccinated demonstrated a VE of 26%, 19%, and 39% respectively. This result tend to suggest a protective effect, potential protective effect. However, the confidence interval indicated uncertainty. The vaccine effectiveness for ICU admission was 22%, but the confidence interval was wide and crossed 0. For the vaccine, the VE for mortality, it was 45%, also not statistically significant. When we adjust for several factors, fully vaccinated presented a lower 24% lower odds for ICU admission and 39% lower odds for hospital-based mortality. However, this reduction was not statistically significant. The effectiveness of VE did not differ among different age groups. Our subgroup analysis suggests varying levels of vaccine effectiveness in different times intervals since the last vaccination dose. 2 subgroups showed potential effective protective effect as for 6 to 12 months with an adjusted VE of 42%, and 12 to 18 months with adjusted VE of 34%, and it was statistically significant. The effectiveness of different vaccine products varied in this analysis. The Pfizer vaccine appeared to show a potential protective effect after adjusting for several factors, and it was statistically significant. However, for AstraZeneca and Sinopharm vaccines, they did not demonstrate significant protection in this study. So in this analysis of patient admitted to one of the SARI sites in Jordan during an Omicron predominant period, receipt of COVID-19 provided protection against SARI associated with the SARS-CoV-2. However, the VE was lower than seen in other studies, and this is probably due to the longer time delays between the most recent vaccine dose and the symptom onset, with a median of 1.5 years since the last vaccine dose. Our result also suggest or support the concept of waning protection for vaccine against SARI with COVID-19, with a decline in protection of more than 6 to 12 months after the last vaccine, and this is adding to the growing evidence of waning protection for COVID-19 vaccine. Our result also, in our study, we also observed vaccinated SARI patient with COVID-19 experienced less severe outcomes than unvaccinated SARI patient with COVID-19. And last but not least, although we evaluated several confounders, however, residual and unmeasured confounding is possible, especially presented by Dr. Daniel this morning, that the increased proportion of cases that is in earlier studies in the pandemic, more or fewer unvaccinated patient had natural infection. So as a conclusion, in this analysis are the limitations of the study, COVID-19 epidemiological situation and low transmission of COVID-19 resulted in small sample size of cases, and also resulted that the stratification for some variables was not possible and influenced the statistical significance and the precision. Omicron variant circulation during the study period led to low admission rate by its known low severity. more than 70% of the population had a period of 12 months and above since last vaccine dose, and with the concept of waning protection, cases and controls were almost similar in terms of vaccination. And the previous SARS-CoV-2 infection, which is associated with a degree of protection against reinfection, may have led to lower vaccine effectiveness. So we conclude that during COVID-19 period in Jordan, we observed waning protection for vaccine against SARI with COVID-19, and that's confirmed the need of booster doses. Additionally, mRNA vaccine were more effective than inactivated vaccine in this study. Further studies with larger sample size are needed, especially for VEs estimating the VE in preventing admission rather than using SARI admitted patient, and the use of this data set as a comparison group against other population with lower time since last vaccine intake. This is all. Thank you for your attention.
Thank you, Dr. Fatima. Thank you so much. So now I think that this is time to hear also from our focal points in WHO country offices, Iran and Jordan, about your reflection on any key points about your experience in the national study. So first, we will start with Ms. Sirus.
Thank you very much. Very informative presentations and discussion. I'm very happy to be part of this consultation. So I wanted to reflect about the situation in Iran and the capacity exists and expertise and professionalism in Iran for, doing the different studies. As you know, Iran has the integrated system for medical education with service delivery, and it means that in 31 provinces of Iran, we have around 65 University of Medical Sciences. So researchers also, not only in the research center, but also in the experience of the service delivery, they can build upon the different, situation and to work more into the details. So what I wanted to also mention is and thanks, especially thanks to the colleagues in EDP in EMRO region, Dr. Mehnaz, Dr. Zahra, Dr. Kamal, Dr. Gomrol, and on the top of all of them, Dr. Arash Rashidian, for providing this opportunity for the country to have the standardized methodology, tools, and this is a very positive point, and congratulate to all. And Iran, due to having different data sources for electronic health record, for hospital information system, prescription system, electronic prescription system, and categorization and classification of diseases for mortality, morbidity based on international classification. All of them help Iran for better, in the very standardized way to gather this information. And thanks also for the REDCap, because REDCap also was very helpful to gather all this standardized information in one data set and platform. So I wanted also touch upon the capacity of Iran for vaccine production and different platform for producing vaccine. COVID, for example, we have 5 different, platforms, and Iran also not, producing different platform, excluding the DNA, RNA-based one. And this is also based on the global, studies showing that more effectiveness of the vaccine for mRNA-based, DNA-based vaccine rather than inactivated or other protein-based vaccines. So these are the issues we need to also to have real capacity, building the capacity in Iran for based on I wanted to reiterate what Dr. Mehnaz also mentioned, and the objective of this meeting, that we need to prepare and generate a policy based on the evidences. So if evidences showing that we still need to shift from some of the vaccine, which are not mRNA, RNA-based or DNA-based, we have to build and to have the better policies on this. So my suggestion is to having a generic template for reporting, and based on this reporting, sharing with the high level in the country these evidences, and then try to start this journey from evidence informed to making the policy. This is the whole things I wanted to emphasize, and importance of the also sometimes happen the political situation also affecting we have to consider the context of political situation in the country, and to make better and appropriate evidence informed policymaking. Thank you, and over.
Thank you so much, Mr. Thank you. Savario?
Many thanks. I mean, very, very rich presentation again. Let me give you a couple of reflections on two different aspects, the results on one hand and the process on the other hand. Results, despite the fact that we saw many non-significant findings, still you could have, you must have obtained, appreciated many direct and indirect informative, segments, like, the importance of the booster, the importance of the previous infections. These elements were discussed this morning about the relative vaccine effectiveness. And I really liked also the recommendation by Dr. Fatima on recommendation around when to start these studies, depending of the epidemiology of the COVID or respiratory infections. So this is a gold mine, I believe, these kind of studies that, again, despite the primary objective is not met in terms of having significant results, still there are so many informative and important findings that should take into consideration at policy level, but also at operational level. From the process perspective, for me, it was a very, very important experience because I was part of the site visits with the Ministry of Health, Human Resources, at the Ministry of Health level. But it was quite interesting to see, the active incorporation by the Ministry of Health at central level of all the SOPs elements of the study at the SARI sites. So all the studies, including the one of South America, really, it reverberates the importance of SARIs. It reverberates, the importance of investing of this essential public health function within the health system. So this time I go beyond the PhD level, but we're talking of the health system in general. And during the site visits, it was very interesting and very, very nice to see the commitment of, for instance, the director of the SARI site, which was a tertiary level hospital. So a very good understanding and commitment from the different levels, and try to analyze critically the potential flow, the potential bottlenecks in the collection of data. Several times with Dr. Fatima, for instance, at the hospital level, we tried to understand why such a low recruitment of cases and controls. So we try to go through the SOPs, we try to go through the different forms collected, and we try to interview the people at the people that were part of the study at the hospital level, try to understand whether they were matching what was supposed to do by their side. So it was a critical element to reinforce the system level and the surveillance within as a part of the study, but as a part of the continuous health system, strengthening. So, I mean, this is something that could be very, very, it's very, very helpful also from the continuous improvement and capacity building of the national counterpart, whether MOH or, other important institutes. Thank you.
Thank you so much, Savari. I mean, that's absolutely, I mean, I just want to also add to what, my colleagues in the country offices, they mentioned. So, I mean, it's very important to see how we can kind of, I can say, deliver these results for impact. I mean, to inform policymaking, because I was just talking with Kamal right now that, not just in Iran, also in Jordan, we have a kind of negative, results in terms of vaccine effectiveness. And the issue is, in Iran, we don't have the vaccine effectiveness results based on types of vaccines. So this is no cumulative, no kind of vaccines that you have. So we don't know that what is exactly vaccine effectiveness for this specific vaccine in Iran. But I mean, at the end, the result is very similar to what we have seen from Jordan. But this is very important again, particularly, I mean, in point of WHO view, that, how we need to deliver this message, I mean, to policymakers, because, this is very important, that how we need to have some kind of messages out of these results. So, and what Ms. Sirus, you mentioned regarding having one pager fact sheet, something like that, from the results to be circulated among policymakers. I think this is a very good idea. I mean, because of course, as usually we say that, we cannot go for pages for ministries of health, policymakers, and policy developers. So having something like this, I mean, 1 or 2 pages maximum would be very, very, I think, helpful. But what should be included there? This is something that we are also here to not just discuss the processes, the methods, the challenges, and also to discuss that how we need to, what figures should be there, how we need to kind of translate these figures to policy statements. So this is very important that, I would be very grateful if also, I mean, of course, today and also tomorrow we have a specific session on that to discuss how we need to also go, I mean, for this kind of discussion. So and now, I mean, we have about till 1:10, 20 minutes for discussion or question and answer. So I myself, I have some questions regarding PAHO, but I prefer colleagues, to start with you if you have any questions. And I know that, Kamal, you have also a question from PAHO, if you want to share with us.
If I still remember it.
Dr. Lace, Hans, and Malika, please inform me about online colleagues, please.
Yeah, so a really great experience from PAHO. Very, very impressive. I mean, I wish we could even have something like this in our region as well. I'm actually curious, especially about influenza and capturing influenza vaccination history. I mean, COVID vaccine is much easier because we had much better registries. But how are you capturing it? Or are you resorting to self-report, which could substantially bias the results? And also in terms of future, are you thinking of adding RSV as well, that the vaccine is coming? Yeah, thank you.
Francisco, just before that. So Dr. Lace, just to make it clear, because maybe, so we will have the same. I mean, in our region, look, now we are just presenting the results of the national studies, but we have also the regional, results. So, but, we preferred to go through each study to show that, for example, what was the results from Jordan, Iran, Pakistan, and then we have a kind of regional pooling all this data, regional data and regional analysis also as well, but not just on SARI, also on cohort, study design. Okay, thank you so much, please, Francisco.
Thank you. And then these are really good 2 questions. One of the good things of the pandemic is that the countries, they had developed electronic registries for immunizations. That facilitated a lot, crossing and matching registries from surveillance laboratory and vaccination status. This is something critical. So we knew for each of the patients the vaccination status on real time with the electronic registry, immunization registries, right? This is not the case for influenza. And we had to invest a lot of efforts and funds to recover this vaccination, influenza vaccination status from patients, hospitalized patients. We do that only documented. We don't use verbal, oral vaccination status. We need the vaccination date. We need to ascertain that it is vaccinated in the current season and when, to also establish some kind of relation between time since vaccination. And so there is some investigation, field investigations when the patient is hospitalized to really determine the vaccination status for flu. Now that things are changing and countries are realizing that this is really convenient to have an electronic immunizations registry for all vaccines, including influenza. So we are moving from paper-based influenza vaccination cards to electronic influenza for all vaccines registries in the regions. That's one of the priorities from the immunization program. Regarding the second question, RSV, we are preparing the network for the introduction of RSV vaccine in pregnant women. You know, as probably some of the countries will introduce the RSV vaccine in pregnant women next season in the Southern Hemisphere. It starts in March. So we are preparing the network, the REVELAC network, to capture infants up to 6 months of age in the hospitals, but also to match with the vaccination status of the mother to see if the mother was vaccinated with RSV during the pregnancy. But this is something that we are still on process. The thing is that we adapted the REVELAC network from influenza to COVID, and we can do that as well for RSV and other respiratory virus. Yeah, thank you.
Okay, so are you, sorry, Francisco, sorry. So Dr. Najafi, Dr. Nabil, and Dr. Nawal.
Okay, thank you. Just a very technical question about the analysis of data. I'm not quite sure who want to answer this question, because this was first my question, that regarding the statistical analysis, when we did the statistical analysis for deaths and ICU, the type of command that we use in this data, we just again put the cases and control as an dependent variable, and then vaccination as an exposure condition on first deaths or ICU. Because if you want to just stick on the design of a study, test negative case control study, we should do that. But you can do the alternative way, which is putting the deaths or ICU admission as an outcome variable, and then vaccination. But this is not the test negative case control design. If you want to stick on the test negative case control design, meaning that we need to put the case and control as an outcome variable, and then vaccination as an exposure, and then condition on this analysis on deaths or ICU admission. This is a very technical question. The result is not so different, but there are some differences.
Thank you for sharing experience between different countries. It is very interesting. And I have also one technical question regarding the Iranian study. I want to ask about the doctor said that it is evaluation of the presence of RNA of the virus is done in 8 hospitals. So how he ensure the unification of the RT-PCR in the all hospitals regarding the control, regarding the limit of detection, regarding the target gene itself? Is there any unification?
The idea was that this in each university or province, there are a central lab. Yes. Confirm all the process with the Institute of Pasteur. So all these university lab have been confirmed with the Institute of Pasteur Institute in Iran. regarding the process and how they can manage the RT-PCR or something like this.
The
So,
same kit is used in all 8 hospitals?
pardon?
The same kit is used for all 8 hospitals?
Yeah.
Okay, thank you.
I mean, the same kits in all hospitals?
For
are-
RT-PCR, yes.
Thank you.
Yes, thank you. So my question to Dr. Fatma, and I think the same applies to also Iran. When you notice there is a low effectiveness, was there any correlation with the real epidemiology around the same time? Like, did you notice increase in hospitalization, intensive care, or death?
Okay, so thank you for your question. Yes, we have noticed this earlier during the study period when we did the interim report, the mid-interim report, and it was like low VE also, but it is explained by the epidemiological situation during all the study period. If you remember the first slides of my presentation, we had a very low incidence death rate and hospital occupancy rate at that time with Omicron circulation, which is known by its low severity. So yes, it was a little bit explained by the epidemiological situation of first, the low effectiveness by epidemiological situation. Second, by Omicron circulation, and by the long period time between the last vaccine dose and the onset symptom. The median period was 1.5 years since last vaccine period. So this can be explained, the low effectiveness can be explained by this long period during for all the study participants.
Thank you.
And this is recommendations for boosters.
Speak up, please, because colleagues online, they cannot hear you. Thank you.
Thank you. I want us to ask some studies using Cox regression analysis for calculating vaccine effectiveness, while others using logistic regression analysis. What is the difference between the two? This for Manuela?
Manuela, I mean, there are two questions, one from Dr. Najafi and one from Dr. Salama to you. So Malika.
Thank you for the presentations. My question is to colleagues from Iran and Jordan. Could the results have been related to the implementation of lockdown policies or other like mask usage policies in place in the country at that time period? And that could be a cause of the low sample or low cases. Was that investigated? Thank you.
Yes. Thank you. As mentioned, when we started the study, all the kinds of restrictions were released. We started the study in June 2022 with a low circulation of SARS-CoV-2, and there was like no restrictions. So the low vaccination, the low VE was explained by other factors that I have mentioned previously, but not for the restrictions and other things as you mentioned.
And I mean, in Iran, we didn't actually take into account such type of restriction for vaccine effectiveness. But as Fatima said, in Iran as well, during the study, during the period of our study, all these restriction has been released. So, yeah.
An addition, please. And if this is the case, it will not affect the vaccine effectiveness. Even that, we will have cases if the study has been done earlier in the pandemic when there was unvaccinated patient with fewer cases or fewer controls having infection, natural infections. So it will be different result. This is another type of studies in another time interval and should be compared to earlier studies in the pandemic.
Actually, we did collect data about social activities and behavior, and we did like analysis in the background, and we found any difference in the VE among the stratified analysis we did.
Thank you, Sawaria.
Couple of questions for Francisco for the PAHO experience. I was wondering whether, because you presented the pooled results, I was wondering whether some countries behaved in terms of results like the pooled one, or there were some divergent results. Second one, the age group, as I understood, was above 18. I was wondering whether some countries included, for whatever reason, like Jordan did, younger children. And if so, if there are results that might be compared to the Jordan ones. And third one, so the study was based on study sites. I was wondering whether all study sites for all countries were part of the study, or only some of them in some countries, just thinking about selection bias. Thank you.
Okay, so so let me just, I also want to raise one. It's not the kind of question, maybe I want to raise another also discussion just to think that's because we are talking about national studies and regional studies, but I'm thinking also if we can have a kind of, beyond regional study, going to pulling the results from EMRO, also with PAHO, and if possible with other regions. I think that would be also very helpful. So this, I just wanted to raise it so we can discuss this also later, how we can also merge all this, pool this all data together, because you have test negative design studies and we have two test negative design studies here also, how we can merge them maybe with Europe and other regions as well to have a kind of global and also results. So before going to your question, Dr. Rashid, maybe Manuel, I don't know, yourself or Thomas or Carsten, they want to just take these two questions, one from Dr. Najafi and another one from Dr. Salama. If you can answer yourself, please. And then Dr. Rashid.
Yes, I will start with a question from Dr. Salama. So that was with using Cox regression or logistic regression. So this is depending on the study design, and also for the cohort you have over time. So you're looking at the hazard rate over time, and the regression that you can do is this Cox proportional regression model. Whereas in a TND study, it's not over time, sorry. And there you have the odds of cases and controls. So you cannot do this rate. So you have the odds of controls to be vaccinated and cases to have been vaccinated. And then for a cohort, you can also distinguish between the Cox regression and doing a Poisson regression, depending on the distribution. And then for this, sorry, thank you for the microphone, whoever was there. For the Dr. Najafi, your question, I think that's a good one for data to be conditioned or using death and not death as an outcome. I think I will have to get back to you on that one just to be sure to give the correct answer. Or maybe if colleagues on the call or online have an answer right now.
The second option, condition on death. I use the condition on death and ICU admission for the analysis, because the other way around is just case control study. It's not test negative case control study. Okay, so I use it just cases as the outcome, and then vaccine as exposure, condition on death or ICU admission. But the result is not so different.
I think also, Kamal, you have kind of
Yeah, actually, I wanted to discuss this, but maybe Manuela has, I don't know if Carsten or Thomas would like to come to this specific question, because this is a highly technical question related to the case control study.
Okay, go ahead, please.
No, please, Carsten. This specific question to Dr. Najafi is a subspecialty in the analysis of the case control study, and maybe you can shed some light on this.
Yeah, and I think the test negative design actually is essentially just trying to reduce the bias that would otherwise be, available or be an issue if access to healthcare would not be controlled for by this design. So essentially analyzing it as if it was just a case control study without that bias would be my first go, and this is probably what you have done. Given that you have done the same, then again, conditioning, and as you say, there is relatively little changes in the estimates, I would say that, it essentially gives proof to the fact that there is not such a huge influence of these issues. So we could look at those data again, and since we have these data, we will certainly want to look at those in the analysis that hasn't yet been done in the way that you have described by us. And I think in collaboration with you, we'll probably be able to sort these things out going forward. But this is certainly a very important issue to look at again, now that we have the final set of data over.
Thank you.
Yeah, thank you very much, Carson, for that. I just wanted to, maybe I understood the way of Dr. Najafi has put the question. This could be a subset of analysis within these studies. Now we're not talking about cases and controls. Now we're talking about factor affecting the admission or the death. So I think in this case, there is no harm to take this subset of data only related to cases and start to study the variables, the founders, co-founders in developing ICU admission or death. So just we analyze this, we can do this through multivariate analysis to see what are the factors which are significantly affecting either death or ICU. I think this is a subset of analysis which doesn't hinder the design of the study.
Dr. Kamal, the problem is that by doing that, you are looking at the, for example, deaths, even if it occurred to the cases or control. So you are combining the cases and control as deaths, and then you are looking at the association between vaccination and deaths. So in such analysis,
it's not case control.
It doesn't matter whether the deaths occur for cases or control, but we are especially looking at the effect of vaccination and comparing it between cases and control. So this is the specific, the aim for the test negative case control study is just looking at deaths, ICU admission between cases and control affecting by vaccination status. So that's why I am still thinking that probably the best way to looking at this data is just conditioning on deaths or ICU by putting the cases or control as a outcome variable, as a dependent variable. I can describe it.
I will discuss it with you alone, but here we're gonna put the dependent variable. The outcome is death, only death.
Dependent.
Then the independent variables, you can put it as a case of control. Number two, the vaccination status, and maybe also premorbid condition, but maybe premorbid condition are also playing in the death. So we would consider it, but this could be a subset of analysis, maybe outside the forum of this discussion, not to perplex the people.
Yeah, let's to go for other questions. It's relevant to this. So very short, please.
Because what we have done in Jordan, maybe it's a little bit different from your study, because we explored the vaccine effectiveness in preventing ICU admission and death among cases, just cases without controls. So this is what we have explored. Yeah, it's not like cases and controls, then death and ICU admission. It is not a test negative design, but as mentioned by Dr. Kamal, you can do this as subset among cases. If you are doing that cases and controls, it will be a little bit different in evaluating VE COVID-19 VE. This is the trick. But when you take cases, just cases as subset. This is different.
Thank you. Thank you, Dr. Fatima. So
thank you. Thank you for all your informative and nice presentations. My question here is, I think for the three countries, Jordan, Iran, and Baho. It is about the data sources. Just asking about if you have used the two different data sources for the study, one for the demographic and epidemiological data and the other for vaccine data, or you have one data set or data source for all the study data, as a result, and based on the results of this study, what are you going to do? Are you going to recommend, if you have been using two different data sets or data sources, are you going to recommend using a common data set with all the variables inside, including epidemiological and vaccine data? And what are the major variables you are going to add or to modify based on the results of these studies? And I think it was another question, but I think Fatima answered this question about the vaccine effectiveness that was lower than other studies in the region or in other regions also. But mainly, my question is about what are the results, the major results, or the major thing you are going to highlight based on the studies you have done. Thank you.
Thank you so much. So I think that now you have two questions. The first one is the data sources, and the second one is, how we're going to. So for the second one, let's do it, later, because we will have sessions specifically to discuss that, how we are going to inform policy making, using this results. So we can take this, for that session. But for the first one already is three questions, because there is from, Iran, Jordan, and Paho. So maybe very short, you can just answer that you had just one set of data or two sources, please. Yeah.
Well, we're using the SARS surveillance, and this is a syndromic surveillance. So hospitals record or collect this information on the admission based on syndromes or clinical presentation. Then we match with the laboratory results, which is not always the same source of information. We have to match patient syndromic clinical presentation with the lab results. And then we have to obtain or collect the vaccination status from the immunization registry. So there are three potential sources, and this is actually one of the challenges we have. We are lucky that for COVID is electronic immunization registry, but not for the other, like flu. So this is always a challenge. That's my comment. Thank you.
Just very brief. Yeah, we use two data sources. One for clinical manifestation for hospitalized patient. Also, we had all information about the vaccination in hospital for patient admitted in hospital, but we try to use the national data for COVID-19 vaccination in order to validate the record of vaccination in our data. So we link two data sources, but we had all the information in MCMC. Just for validation, we used another data.
Yes, thank you. We have used many data sources. Maybe the strength of the study that having a SARI surveillance in country have helped us in having the database for the study. However, more variables and extra variables were to be collected. So we used an interview, patient physicians interviews completed by electronic medical records using SARI database for completing and for validation of data. And also we used the COVID-19, the national COVID-19 vaccine record registry for the vaccination status of patients.
And let me just conclude something here that, of course, as usual, I mean, as always, we always recommend integrated information health systems. So having one health information system in the country, having all this together, it is the best option. So this is the final recommendation.
I'm so sorry, ma'am. Can I just say that there's a hand up online?
Yeah, I saw. Thank you. So Karsten, please.
Yes, thank you. Just on the last point, the integrated immunization registration systems, of course, are relatively complex to do, specifically if they have to be also linked to a CRBS, or a civil registration and vital statistics system. So we've seen that, of course, happening in many, many countries, and it is a relatively long process to get this done. But that was an aside just on this one. I wanted to come back to the Jordan study and the issue of depletion of susceptibles, which could be one of the causes or reasons for the low VE found. We would, and we have seen, of course, in Jordan in blood donors, and also from a Unity study, background studies on seroprevalence, that this has, of course, risen quite dramatically from 2020 to 2022 when this study was started. So there may really be an issue here of having the low circulation of the virus, as you very rightly said, in the control population by the natural infection effect, thus significantly reducing the VE estimate. So we'll have to look into that by looking at the data that we have available on seroprevalence in the country going forward. Thank you.
Thank you, Karsten. So I cannot see any hands on Zoom. So I think that we have our last comments or question from Manuela, please.
Yeah, just wanted to briefly get back to the question from Dr. Najafi on Iran. So now we paused it for the break, but I just wanted to point out that depending on whether to have the death among cases only, which is then deaths due to COVID, or deaths between cases and controls, this would be all-cause deaths. So depending on how to do it, it would also change the interpretation, and depending on your question, just wanted to make this distinction between deaths due to COVID or overall.
So I cannot see any hands on Zoom, and also here, colleagues. Please, just short, because.
Just to add on Dr. Marshall, what he said, yes, it is right tool, but using SARI population in this study in such epidemiological situation in countries has also contributed to the low VE, because there were like low admission rates in that time, and if low admission rates, it means low SARI cases in terms of cases, because SARI cases are there around the year for many other reasons and viruses and bacteria. But for SARS-CoV-2, there were very, very low admission rate, and this influenced the small sample size of cases and also resulted to the wide confidence interval and statistical significance.
Thank you. Just Savario reminded me that he has questions. I mean, he had the question from you, Paul. So you remember the questions? So you have them. So if you can just reply to that, and then we can end this session. Okay, please.
So your first question was about the pooled analysis. This is a regional pool analysis I presented, but some countries conducted national analysis and they obtained their national estimates, but they needed enough sample size to do that. Not all of them reached the enough sample size to have VE by age group, by type of vaccine, and by period. That's complicated. That's why we present this regional. This is the case of Chile and Paraguay. They presented the national estimates. For influenza, we are conducting even subnational estimations at they call regions in the country, right? This is the case for Brazil. Brazil is a huge country, and some of the states, regions are like countries in other, so, and they are interested actually to get subnational estimates by region to inform decision making. This is for flu. We know that in the northern Brazil, they have a different circulation of influenza than the south. So they are considering changing the southern hemisphere to northern hemisphere formulation for influenza based on the vaccine effectiveness. So this is an example of using vaccine effectiveness to guide policy or changes in terms of vaccination strategies. Second question was about the children. We excluded from the analysis. I didn't present, but we are doing a side analysis for children. That was a lot of information. We collected a lot of information. We collect anyone hospitalized in the sentinel sites. Then we do the analysis. So we will have a separate analysis for children only during Omicron because they started to be vaccinated during Omicron. And the third question was about the SARI sites. During COVID, the Sentinel system was not working properly. There were a lot of problems. So we tried to reestablish the SARI Sentinels network, and it took some time. Not all SARI sites participated in the beginning, but now they are already reached the pre-pandemic level. There was a question about the global pooling with different across regions. This is something I already asked to Danny and Minal some time ago. Since we are using the test narrative design, we're using the WHO SARI case definition, we're using the PCR as a confirmatory test, we could potentially pool the data. We are using the same approach, especially for vaccines that are not widely used. We had a low precision in some of the vaccines. Sputnik, Sinopharm, they are because not been used really in large populations. So if we do some pooling, we can obtain more precise estimates with other regions, especially for non-vaccines. And we are doing actually this for flu. For influenza, we are pulling data from southern hemisphere countries, Latin America, South Africa, Australia, New Zealand. We are pulling data to get southern hemisphere estimates for influenza. So I think it's a great initiative that we can explore. Yeah.
This is also later. So I think that now there is no more questions or comments. Yes, am I right? Oh, okay. The last one. Okay.
Okay, thank you. So my comment is the endpoint of this case control study is having SARI or not, or having SARI. Both of them, case and control, has SARI, but who was positive or negative. I mean, if we really want to influence decision makers, I think we need to have a more severe outcome, even ICU admission or death. I mean, if I'm a decision maker and you told me like, okay, vaccine is effective to have negative against being negative or positive, it's better tell me like, okay, vaccine is effective against ICU admission or not. I think we have a large amount of data. I mean, in Jordan, we had VE was not really, vaccine was not effective against ICU admission or death the way we did it. But if we collect data from different countries and we do this analysis somehow, just to prove them like the vaccine is effective against ICU admission or death or any other severe endpoint. Thank you.
Thank you so much. I think that tomorrow in the session that we have with Manuela, Thomas, and Carsten regarding the statistical, session. I think there we will discuss also a bit about the regional pooling data that is also a part of our plan in the regional studies. So then, we will, of course, elaborate more on your question, Ahmed. So let me say that finish and khalas this session. So we will have and I know that if I say now that we will have less than 1 hour for lunch, everyone will be a bit angry at me, yes. So let's go. No, nothing, no objections. So okay, so now is I can say it's 1:25. Let's go for lunch, and we will come back at 2:20.
Thank you so much for giving us the opportunity, and our country colleague, Dr. Palita and Dr. Michael, to be part of this important study. We are also one of the NEDT member, Khyber Medical University. It's one of the largest medical university in Pakistan, which has 26 medical schools attached to it. So, and also we have 210 institutes. We have 64,000 student body, and we have the teaching hospital affiliated here. So this study was vaccine effectiveness in healthcare worker at tertiary care hospital of Khyber Pakhtunkhwa. This is one of the province of Pakistan, in a cohort study. With me, I have Shiraz Fazid, who is online. He couldn't get the visa, but he's online with us. And our country colleague, Dr. Michael, is here. Dr. Palita, who was with us since the inception of the study. So in Pakistan, like this is a figure from 25th October. So we have 1.5 million confirmed cases, and we have nearly 31,000 reported deaths. There are news that we have more deaths, but this is what has been reported. So we have done reasonably well in Pakistan. It was not expected from us, but Alhamdulillah, our health system responded well, and WHO has a greater role in that. So we had 7 types of vaccine that were approved and available in Pakistan. This is Sinopharm, Sinovac. Majority used these first 2, but we also had AstraZeneca, Sputnik, Pfizer, and Moderna. And eligibility for vaccination, we started in February 2021, and we prioritized it. The first 2 months, we have a lot of deaths in healthcare workers, senior professors died, and we also have the nurses and paramedics died. And then the government prioritized that we should have the healthcare workers should be given the vaccine when it came, and then also the elderly population. So the variants of concern in Pakistan, it was the same in other countries. The first, in all the 6 ways, we have all these strains which were prevalent in other part of the world. So the study objective, the primary objective of our study was to measure against symptomatic PCR confirm infection amongst all hospital healthcare workers eligible for vaccination. It was the primary objective, and the secondary was the same, but it was infection for the people without previous infection. And then the secondary objective was the same for reinfection for the participant with previous infection. So we call it retrospective cohort study. There's a debate on this, and you can still call it some another study. But anyway, this is a follow-up study in which we took people from exposure and we followed it for 1 year. And the hospital which we selected, these are the Khyber Medical University affiliated teaching hospitals. These are more than 500-bed hospital. We have Mardan Medical Complex, we have Seju Teaching Hospital, and DHQ Hospital Quad. They were randomly selected for this study. At the start, we have 20 November 21 to 30 December 22, and eligibility criteria is a healthcare worker. Active follow-up, we followed for every 15 days. So our health research associate, they used to go and ask and document all these healthcare workers, and then we could test them for the symptoms. These symptoms are given, these are WHO definitions. So whatever symptoms they reported, we have done the PCR at that time. And the data collection tool, we use the WHO in hospital follow-up tool, and also develop concept and follow-up. And the PCR we done in one laboratory, that is National Institute of Health, Pakistan. So the enrollment, we started with 1,707, 2016 didn't participate, and 1,491 total study participants who agreed for the study. We lost some of them, 203, and the end, those who completed the full study, that was 1,288, but we had this 1,491 is our study participant. The specimen was nasopharyngeal swab, and we also took blood sample at the baseline and end line to see the antibodies. And the specimen we collected and sent it to National Institute of Health as a one lab to do all these PCR for us. And serology test, we did NTS antibodies for detection of vaccine-related antibodies. We didn't use much them in analysis for the reason you know. So we used the red cap. That was a wonderful experience. One objective of this study, which EMRO is doing, that's also our capacity building. So we had numerous meetings, and thank you so much. We learned a lot from you. And one is this red cap. There's Dr. Kamal said that it has its own strength over the data and other software, because it's a follow-up data which we struggle at the start, but then gradually and slowly we are in love with this red cap, and we are very happy now with this. And we had a lot of queries which we raised till last week. So descriptive analysis, the chi-square we used. And then the survival analysis we have done, in which we took the endpoint 3, which is occurrence of the event, refused to participate, or completion of the 24th of follow. So all 3 was taken as the endpoint for the survival analysis. So Cox proportional hazard model were used. And as in the Cox proportional model, we use vaccine effectiveness 1 minus hazard ratio. We also did the sensitivity analysis. So background, we have this 1,491, in which we have this 13.8% of the study participant lost to follow-up. Mean age of our participant were 34.1. These are all healthcare workers working in the hospital. And then 25% were female. And among the study participants, the prevalence of existing comorbid was 6.9%. So this is just an overview of the large table, which shows the study characteristic. The same is this. I will go straight away to the result side. This is one of the survivalist analysis curve. You can see that with time, I will be explaining this. Then the difference between the 3 is that the lower one we got in Mardan, and then in the middle we have SWAT and cohort. We have a good response, but you can see, I can just explain this in further slide. So this, you can see that fully vaccinated, you see the adjusted, if you focus on the last one, so the adjusted vaccine effectiveness percentage, fully vaccinated, that is 30%, and without prior infection was 20%, and fully vaccinated with prior infection was 40%. In comparison, the reference point for this was the partially vaccinated. So you see that the crude and adjusted, this is the vaccine effectiveness. You can see that I have highlighted those with significant result, and see that one study site, the Mardan, which is 4.12 hazard ratio compared to cohort, and SWAT we have 2.42, and similarly underweight, and those working in emergency were protective. So maybe the reason for that the emergency people, they were strict guidelines from the hospital to use PPEs. And others didn't use, so maybe that's the reason. And for the study site Mardan, which is higher number, so maybe the SOPs which they are following, the number of cases they are seeing, that may be an issue. So the same is for the no prior infection. So the same pattern we saw, the same hospital site in protective and working in emergency. So interpretation, over the course of the study, a total of 1962 times symptoms were developed by the study participants, and incidence of symptomatic COVID was 10%. The overall vaccine effectiveness says is 30%. Among the participants have no prior was 20, and those with prior infection was 40%. Among the incident cases of COVID-19, all the cases developed mild infection of SARS-CoV-19, and none of these were admitted to the hospital. That was significant findings in which we shared some of the code with the policymaker, but this is again, which can be shown because none of them, they were healthcare worker exposed, but none of them were hospital, and they all got mild symptoms. So on multivariate, they say that the Mardan site, underweight, they were significant. So limitation, we had a history of COVID-19 prior to vaccination for COVID-19, majority of diagnosed that is before on the rapid test, and no further confirmed the right PCR. There was no control over that. Also, some of the, we started late because they got vaccination before, so the mean duration of follow-up was lesser in some of the participants, and 25% of the participants. And among the vaccine administration, majority were Sinopharm and Sinovac they have used, so the others were lesser used. And then all this was Omicron area, so majority of the analysis remains to that Omicron. So our conclusion and recommendation is that vaccination of COVID-19 proved to be effective against symptomatic COVID-19 infection in workers against working in tertiary care hospital, and booster dose of COVID-19 vaccine provided additional benefit in reducing the symptoms, although the p-value maybe because of the number were not significant. So all eligible adults should receive booster doses. The registration for the COVID-19 vaccination must be completed to ensure that all participants have received the required vaccination. And all healthcare workers should be adopt the uniform SOPs that maybe we think is one of the reasons for the higher number of HR in two hospitals. And the last slide was the acknowledgement could have never ever done this without Palita, Dr. Palita, who's our WR, a good friend. Michael is a brother to us, and he is so kind to Cairo Medical University, and always taking guidance from them. Arsh Mirnaz is like a family member. We have seen her so much in those meetings. Dr. Kamal was there, and then the wonderful team of Madeline, Jehan, Kirsten, all those, he's also present here. So we all learned from you all. It was a wonderful exercise. Thank you so much for having us. Yeah. Apologies if I missed someone. Thank you so much. Thank you. This is my last slide.
Thank you so much, Dr. Zia. Thank you so much for the great presentation. Dr. Nabil, you have 15 minutes. Thank you.
Cohort study to measure COVID-19 vaccine effectiveness among health workers in 5 university hospitals related to Al-Azhar University. Regarding Egypt, the first reported case was by the middle of March 2020, and then till the end of May 2022, 5 waves of COVID-19 was recorded. The first wave, Alpha variant was the dominant variant, while for the second and the third waves, Alpha C36 was the dominant variant. Then in the fourth wave, Delta variant was the dominant one. And the fifth wave that started by the beginning of the year 2022 and remains for 16 weeks, Omicron variant was the common variant. And EG5 was reported last August. Beta variant was not detected in Egypt. And we can see here, this is the period where the enrollment of our cohort was taking place. It is within 2 months, July and August. And as I told you, Omicron was the predominant at that time, and it's well known that it has a high transmissibility, but low mortality and morbidity. And this is what's actually reported since the last death was reported in Egypt in March 2023. Regarding the vaccines available in Egypt, almost the common vaccines available all over the world was included in our in Egypt, but most of them were included in our cohort: Sinopharm, AstraZeneca, Johnson & Johnson, Sinovac, Pfizer, and Moderna. Regarding the study, it is a retrospective and prospective cohort study. Enrollment dates for 2 months, July and August 2022, and the estimated sample size was 1,006, according to the WHO recommendations, while the actual recruited participants was 1,249 because of the dropout. Participating study sites were 5 university hospitals affiliated to Al-Azhar University. Al-Hussein, Bab al-Shariah, and Al-Zahra are present in Cairo. Damaita, Al-Azhar University Hospital, is present in the north of Egypt, in Damaita, and Asyut, Al-Azhar University Hospital, is allocated in Asyut, which is a governorate at the south of Egypt. The study objectives are to measure the SARS-CoV-2 vaccine. The study objectives, primary objectives, is to measure the SARS-CoV-2 vaccine effectiveness among healthcare workers eligible for vaccination at Al-Azhar University hospitals against symptomatic confirmed RT-PCR SARS-CoV-2 infection, while the secondary objectives are to measure SARS-CoV-2 among individuals who have been partially vaccinated compared to those who are fully vaccinated, and among vaccinated previously infected compared to unvaccinated previously infected participants. While follow-up objectives is to identify among the cohort participant health workers new cases or any change in vaccination status or change in the potential exposure. All participants groups were followed up bi-weekly through a follow-up questionnaire. Any participants who develop symptoms consistent with COVID-19 suspected case definition have to provide nasopharyngeal swab to be tested for SARS-CoV-2 by RT-PCR. Data collection and management started by orientation camps for all the study team in the 5 university hospitals, and the questionnaires were fulfilled at enrollment and during follow-up. Also, virology and serology questionnaires were fulfilled during the process of laboratory analysis. Data was entry was carried out using the wonderful system or program, the RedCap. The data was modified according to what was recommended by the MMGH colleagues. Descriptive analysis as number and percent for qualitative data was presented, and median and in quartile range of for quantitative data. Vaccine effectiveness was calculated using Cox regression analysis, and sensitivity analysis was also done. Laboratory methods, including specimen collection. At enrollment, we have nasopharyngeal specimen for RT-PCR and serum for testing the binding antibodies for COVID-19 by COVID-19 to immunoassay that is developed by Roche. Specimen storage, shipment, and transport was followed the recommendations of the WHO. Regarding the RT-PCR, we have using the ARTAS SARS-CoV-2 PrEP and AMP mini kit with sample preparation and the detection steps integrated in one single kit, target 2 viral genes N1 and N2 with controls, and the limit of detection is 950 copies per ml, but invalid samples were recognized that we shift these invalid samples to another extraction kit, which is Kaya AMP DSP virus kit, which give good results. Regarding the included participants, we have actually 1,257 healthcare workers. 8 of them refused to have their consent, so the actual sample size was 1,249. Part of them were unvaccinated, partially vaccinated, fully vaccinated, or even have a booster dose. All of them were tested for the binding antibody. 1 of them was also only missing, and the 3 were negative, while all of them were positive, even highly positive. You have to dilute the samples 1 in 10 in order to receive actual quantity for the binding antibodies. 1,249 were positive. 53 of them having binding antibodies more than 1,000 having antibodies more than 2,500. Regarding the PCR, 14 were excluded because 7 of them were having nasopharyngeal swabs dries because of long storage, and the other 7 because of still inconsistent invalid samples. So we only have the test for 1,235 samples. 119 were positive for COVID-19 RNA. While the follow-up was done for all the participants bi-weekly for 1 year, and only 232 were symptomatizing, and those who were symptomatizing, we asked them to provide nasopharyngeal swabs, but only 108 provided the respiratory samples. Of these 108, 18 samples were positive for COVID-19 RNA. So the total cohort showed that the mean age was 107 were unvaccinated, 52 were having partial vaccination with only 1 dose, and full vaccinations is received in 73%, and booster dose was detected in 14%. Most of the cohort was females, and most of them were nurses, and the chronic conditions is only present in 25% of cases, and most of them either suffering from diabetes or hypertension. Regarding the vaccines, the most common vaccine is Sinopharm, followed by AstraZeneca, then Sinovac and Pfizer gave the similar percentage. Change by mouse here. Okay. Regarding the clinical picture, we noticed that in the total cohort at enrollment, as I told you, that 119 were positive for RNA. 13 of them were symptomatic and 106 were asymptomatic. And this is in accordance to the Omicron variant, which shows a high prevalence among the asymptomatic positive PCR. And as we see in this table, that 11 of them were unvaccinated, 3 will have partial vaccination, 71 having the full primary series, and 21 with booster dose. But again, no morbidity, no mortality was detected in any one of them. Regarding the follow-up, as I told you, 18 were positive. Of these 18, 12 we're seeking the medical care, and 3 of them were unvaccinated, and 3 having partial vaccination, 10 were fully vaccinated, and 2 were having booster dose. But again, no positive PCR requiring hospitalization or mortality or death. Here, the COVID-19 vaccine coverage among the study participants. Vaccination started in Egypt by January 2021. And here we can see that they have the first dose, the second dose, and the third dose is starting to be available by December 2021. And here the cumulative COVID-19 vaccine coverage among the study participants were equally, most of them having the second dose and beginning of the third dose also occur. The figure on the left side show that the positive follow-up cases, as I told you, it is 18 persons, and most of them were recruited the infection during March 2023. While the figure, the graph on the left side, on the right side, sorry, because I'm left-handed, the graph on the right side show that a significant difference between the study group, either non-vaccinated, partial vaccinated, fully vaccinated, or having booster dose, with high risk is present among those who were partially vaccinated. Regarding the vaccine effectiveness against RT-PCR confirmed symptomatic infection, it was found that it's about 40%. And it is increased with the having full primary series of vaccination or even having with the third dose. Regarding the vaccine type, it was found that the vaccine effectiveness is more significant in those who had Sinovac, followed by Sinovac, followed by those having Sinopharm, and the least one is among those who have AstraZeneca. It's of note that no one of those who vaccinated with Pfizer vaccine have got the breakthrough infection through the follow-up of these participants. And it's of note also to see that the last two lines showing that those who were vaccinated and has previously infected or vaccinated with no or unvaccinated with previous infection. And there's significant difference between both, and this is because of the hybrid immunity. The vaccine effect also sensitivity analysis was done, and and this sensitivity analysis shows the vaccine protection, similar results in vaccine protections among 3 groups, either those who have the time between the first dose and the second dose less than 21 days, or those who were vaccinated or and having the previous infection, or those who versus those who were not vaccinated and having previous infection, or also if we reduce the post-infection period to 60 days instead of 90 days. The limitation of the study, starting recruitment of participants before issuing contract, that's reflected in delay in purchasing required kits needed for the study, subsequent delay in laboratory investigation, and that's passively reflected on participants' loss of interest and missing a number of samples. Also, there is a delay in getting the security clearance by the National Research Center, which is our partner concerning with the data management, with subsequent delay in laboratory analysis and rate cap data entry, and vaccine hesitancy is still challenging among healthcare workers. Conclusion, COVID-19 vaccine effectiveness among healthcare workers is between 40 to 60%, with no significant difference between groups. Cumulative instance of COVID-19 infection is significantly higher among those with incomplete vaccination. Sensitivity analysis shows similar results of vaccine protection after exclusion of participants who had duration less than 21 days between first and second dose, decreasing the post-infection period to 60 instead of 90 days. Exclusion of symptomatic patients who refused to give nasopharyngeal swab versus including them in the analysis. Vaccine effectiveness rises up to 80% in those with hybrid immunity compared to unvaccinated healthcare workers with COVID-19 previous infection. Recommendations, the clinical significance of the booster dose vaccination has to be thoroughly investigated. The rise in the antibody titer against SARS-CoV-2 and its duration are important indicators for evaluating the effectiveness of COVID-19 vaccine. Knowing the circulating COVID-19 variant is an issue of concern. And this is the team of the 5 university hospitals affiliated to Al-Azhar University, the team of the National Research Center, and the virology lab at our microbiology department. And any questions? Thank you.
Thank you so much, Dr. Nabil. So I mean that those recommendations, maybe there are some kind of input for discussions. I mean, Manuela, you can have in your session tomorrow regarding those recommendations, particularly the first one, you can maybe share, I mean, you ask, Dr. Nabil to share her slides with you, because the first recommendation, I think that this is something that we can discuss during the statistical, session tomorrow. So now we will listen to country offices for call points for Pakistan and Egypt. So Michael, please, over to you.
Thank you very much. I just want to add on to the voice that has already been said by other colleagues. That is, we appreciate our colleagues from HQ and EMRO for all the technical support they have provided in conducting this study. Yeah, but okay. Yeah. So on technical support for the case of WHO, I think WHO country office started funding it initially, but later I think we got support from EMRO for that and HQ. So we want to appreciate that. We also want to appreciate the same team for building capacity of the country office and for supporting strengthening relationship between WHO country office and Cairo Medical University. We also want to really appreciate Cairo Medical University for leading in this exercise. Cairo.
It's from country office Pakistan, talking about Pakistan.
Sorry. I didn't introduce myself. I thought it was done. So lastly, we still have some work to do to finalize the data analysis, etc. We hope that once it's finalized, we shall have a document to share with the provincial office, the academia, Ministry of Health, and the government of Pakistan to influence the policy the government is going to work to use, and then advocate for more funding for health in such activities. Thank you. That's all I have to say.
Thank you so much, Michael, and thank you for your support also through all the process of this study in Pakistan. So now we will just listen to colleagues from country office Egypt. Yeah, Vala, we have you. Please, if you can hear me, please unmute yourself.
Hello, can you hear me?
Yeah, we can. Thank you.
First, I want to apologize that Amira is not here. She is the focal point, but she's on sick leave. And I want to thank all my colleagues at EMRO WHO headquarters as well for their efforts throughout the study. Unfortunately, I can't open the camera because the internet is unstable. But can you hear me?
Yes, Vala, can
okay.
section on the site visit that we had in Egypt together. Oh yeah, I just ask you if you have any reflection regarding the site visit that we had together.
Yes, absolutely. Actually, as you know, I've recently joined the WHO workforce. I wasn't part of the team when the study started. Yet through my field visit and the interaction with Dr. Zainab Nabil, the principal investigator in Egypt, it was really evident that there has been a remarkable level of commitment, as you said at the beginning of the day. The commitment reaches the highest level. They all want to ensure the successful execution of this project. And one remarkable aspect that struck me during my engagement with this study is the extraordinary caliber. Hello?
Your voice is not clear. If you can just come closer to the mic.
Yes, sure. Do you hear me now?
Yeah, you need to continue speaking to.
Okay, I'm gonna raise my voice as much as I can. So I was mentioning the remarkable level of commitment at the highest level, starting from the principal investigator to the Al-Azhar Dean, and the Azhar University president as well, and the extraordinary calibers of the researchers in Egypt, especially the younger generation, and the capacities of the laboratories we have visited. I think they altogether lay a robust foundation for the sustainability of research initiatives like this one in the country. And I really also want to commend the foresight displayed by the Egyptian PI, Dr. Zainab, and her team. Even before the study officially initiated, they anticipated and they addressed the economic stresses and the issues of importation issues in Egypt, which reflects actually their experience in this field. And they had sort of contingency plans. They were really proactive. They had a proactive approach to address these issues despite the challenges. So I really want to commend this. And from our side in the WHO country office, we are fully committed to support not only the study, but other future research initiatives. Over to you.
Thank you, Vala. Thank you so much. So I want to invite also Mr. Shiraz. If you have any, additional, points that you want to share with us regarding Pakistan, because, I know that, you also worked, on this study a lot, and we are so sorry that you cannot, attend in person due to visa issues. So if you have any further additional, comments or points, please go ahead.
Thank you so much, Dr. Manas, for providing me the opportunity. Yeah, already the presentation has been made by Professor Zia. Things are clear, and whatever we had, he presented well. And yeah, it was a great learning opportunity for me while working with WHO EMRO, and then the EP Concept colleagues, and then at the last MMGH team were there. So it was a very good learning opportunity for myself and our study team. So that's all from our side. Let's hope if we have any questions, so we'll be able to participate, inshallah.
Thank you. And Dr. Salama, anything further from your side for Egypt study, please?
Just I want to thank WHO for learning us the wonderful program, RedCap. It was easy to enter the follow-up data, which we cannot enter without using RedCap. Thank you.
So I need to just flag this that, I mean, at the beginning, it was very hard for all of us to use, RedCap, but I'm so happy that now I see that everyone is happy with it. So, I mean, it really, it's worth to do this and, do the capacity building on RedCap. So now the floor is open for discussion. If you have any questions regarding Egypt and Pakistan studies, or even if you still have any questions, from the previous, technical sessions, please just raise your hands or do this as Savario did, just upright your name stands, please. So Savario, go first.
Well, many thanks again. Very interesting case studies, although quite different from the previous ones. I was wondering for both countries, if you realized during the course of the implementation of the study, if you missed some confounding factor that could have been useful for the final analysis, because being healthcare workers, in the first presentation, there was some mentioning about the use of PPEs that might have contributed to lower or higher rates of risks. Just very broad question, just during the implementation, if you found that you could have added some additional variables to further elaborate the analysis. Over.
Yeah, I think, so this is something that we talked about, and we have some the data, and we will look into it again. We're working with these hospitals. The data is not included within the study, but also outside the study, we have some data. The number of trainings which has been done, number of cases has been done. So we may link for the discussion section, we may relate it to the findings to them.
The WHO customized the questionnaires according to the country itself. And Dr. Iman has a lot of data, but that is not included in the study because of the time limit. She can tell you the actual situation.
We just adjusted the data using age, sex, body mass index, and chronic comorbidities. Regarding the situation in healthcare itself, we didn't do it because this is one drawback of RedCap, that it needs more analysis and more gathering the data together in order to know the situation, and we don't have any time to do this. Later on, we can do the same.
I think this is for the uniformity, we have done all this analysis, but we have the data with us. We have some other variables here, so you can, the point is well taken, and we'll look into this. Yeah.
We already have the data, so it can be analyzed and presented, but we concentrate on the main data.
I mean, it was a bit very similar to also TND. I mean, we had some kind of questionnaires, and according to that, we had some specific, variables and components to be included in that regard. So, so I mean, there may be some more information available in the countries, but we didn't include in RedCap. But it can be done later if any country wants to continue and to have other types of also analysis on other variables. So this is something which is also, I mean, it can be done if the data is available there. So
the data is already present. The data is already present in the RedCap, but separate. Each items of the types of healthcare occupation divided on 20 columns. In order to collect them, we will do this, but later on, just after
the current one. Yes. So Shiraz, your hands is on, please go ahead.
So yeah, what I think that the data collection tool that developed by the WHO was quite expensive and quite helpful. We have a lot of the data, and the first dummy table that were provided by the WHO EMRO team was really helpful, and it helps us. It helped us to come up with the concluded results presenting the overall vaccine effectiveness, and then by type, and then there was booster, then there was relative vaccine effectiveness, and then there was hybrid immunity as well. So everything has been presented, and yeah, we can play around the data. We have all the data, and I think the data is sufficient, whatever has been collected. So there is a lot of information, and as said by the Egypt team, so yeah, we can play around the data and we can come up with some very good results as well. Thank you.
Thank you very much. So this time I wrote it down so as not to forget the 3 questions for the last session. I just wanted to thank you very much, the PI, in doing this kind of analysis with support of MGH and others. We have seen stratification of analysis based on many independent co-founders in many of the studies. But it is the first time now to see in Pakistan that we have added one confounder, which is geographical location. We normally do vaccine effectiveness study everywhere in the world, different countries, because of different perspective. We have more than 60, 70 countries in the world. We have done that. Knowing that Pakistan is the biggest country in the region with more than 220 million population, we understand that we might be disaggregating the data and stratifying the analysis by geography. However, here we are talking about one province, which is KPK, Khyber Pakhtunkhwa. We are not analyzing versus the biggest Punjab or other Sindh, but we are talking about only one province. And in spite of that, we have seen that there is a difference in vaccine effectiveness between Mardan, Swat, and we didn't see any tertiary hospital from Peshawar. Wow. Kohat is within Peshawar. Okay. So now, how we can explain, if we're thinking about publishing or sharing this data, how we would explain a difference in vaccine effectiveness between 2 hospitals in the same province? What could be the factor? We are brainstorming together, and I'm trying to understand, knowing well Pakistan, and I've been working in Pakistan, I don't see a really difference between these 2 hospitals within the same province to have this. Not only a difference is vaccine effectiveness, but it is statistically significant. So the difference is big. So do we have an explanation for that, Dr. Zia?
Yeah, I think this is something we discussed with our group, within our group discussion, that we don't have really a clear answer for that, because it should have worked the same. But maybe we say that, like Mardan, you have worked in Pakistan, so you know that Mardan is somehow the first deaths came in Mardan. And a lot of cases came in Mardan because there's an area in which the people from Gulf and other countries come. And it's a big city now, if you visit now. So these are 3, the Kuhat side is looking after the whole southern region. The Swat is from the mountainous area, and Mardan is linked very near to Islamabad in that place. So maybe you say that maybe the exposure, is more number of cases coming. Mardan was like isolated, and for many months, the whole city was locked down for 3 or 4 months. So I don't know what's the exact answer. We have the data, as we said in previous discussion, that we have the other variables that to look into this. But for the larger presentation, you may not need this. This is because it's only in 3 hospitals which we are discussing, the small group. But if you are presenting it at the regional level, maybe you don't need it. We have the cumulative data as well, so that could be used.
Yeah, it is also helpful for every one of us to understand that not all the data and analysis could be projected in a publication, or we can share it. So some of the analysis and data that we don't have an explanation, we really don't need, because any reviewer would ask why, as I'm asking. I thought about vaccination, but unfortunately we don't have the disaggregated vaccination from different provinces. And here we're not talking about different provinces. Even in the ministry, they wouldn't have a differential vaccination coverage between different areas within the same province. So I just put this question on the table for other people. Maybe we can find an explanation. But it, as I said, results are results and data are data, but we should be always endorse and backed up by an explanation to do that.
I'm not sure if you use is the person protective equipment are used equally between hospitals. I mean, maybe this is one of the reasons why the effectiveness is different between sites. And have you done a multi-level analysis to to control for hospitals? I think also you were kind of sorry, but fishing to adjust for reference group. Maybe if you change the reference group, the result maybe get different.
Yes, so the first one, as you said, no, the hospitals are completely different. It's very independent in Pakistan now. So it's like American system brought in the last 3 years. So every hospital is different. It's its own BUG, Board of Governors. And so the doctors are now employee of the Board of Governors. They're not employee of the health department. So even all healthcare workers, so it's totally different. The area totally different. Yes, the PPE use, it depends on the hospital administration, how they behave, and also the caseload as well. So Mardan is the central area, which is a lot of the caseload. So that's what maybe the potential answer for us. But yes, like in the large group, you may not be able to present, but sometimes, Dr. Kamal, we are not shy of presenting thing, so it can create a debate, even if for the publication, if you present it, so there will be different answers for them, and then there will be further research. So these are research question for further research as well, I think.
Okay, any further question? I ask you to please do not ask all your questions in the first discussion session. So now I see that there is no more question here. So online colleagues? Okay, so we can, because we'll have our last break just to take some coffee and tea. I mean, for us as Oriental, or I can say Eastern Mediterranean part of global world, so we used to have some coffee and tea after lunch. So but I mean, it will take time to be ready, so maybe we can go for the first presentation from the last session, Dr. Lace, and then we will go for a very short 10 minutes coffee break and come back for the rest of the presentations. So if you can put, yes.
Okay, good afternoon. So in our Qatar experience, probably the defining feature is the effective partnership between the government and the academic sector during the pandemic. So we worked very closely from the before even the first wave to appear. And one of the features of this working together is that we structured the databases in such a way that they will allow actually, sorry, I just got surprised by the putting on the spot. Yeah, so we structured the databases in such a way that they are amenable for research. So before even the first wave, the whole data capture system in the country was structured to be actually amenable for scientific research. So one contributing factor to this is that we have an advanced digital health platform in the country, the Cerner system, where all data get captured in this universal public healthcare system. So here are a few features about our databases. First, the completeness of the databases. Everything that happens to COVID-19 get captured in this Cerner system, whether it's vaccination, whether it's testing, PCR testing, rapid antigen testing in medically supervised ones, and so on. Every test is associated with the reason for testing. And also, we used not hospitalization as a criteria for severity. Throughout the pandemic, we use COVID-19 severity, criticality, and fatality strictly per WHO criteria. So every case of COVID-19 was reviewed through chart reviews to determine actually the severity. We never use hospitalization as a criteria for severity. So these are about the databases. Databases are only one aspect, of course. We needed more in order to power epidemiologic studies. We needed genomic surveillance. So this is why we did also added two components. The first one is viral genome sequencing of weekly random samples. And we added also real-time PCR genotyping of SARS-CoV-2 infections. And this continued throughout the pandemic. So very much we had really the different pieces together to power a range of epidemiologic studies of different kinds. And we have been fortunate giving these databases to apply really all kinds of epidemiologic study designs, test negative, other case control, cohort design, target trial designs, cross-sectional designs, and so on. So the meeting today is about vaccine effectiveness. So I'll just mention a few things about what we have done. So we have been using in Qatar only mRNA vaccines, Pfizer's and Moderna. So, and we started working on vaccine effectiveness studies when we started vaccination. And at the time, of course, the big question was, how will these mRNA vaccines will work against the alpha and beta variants, which were actually circulating at the time. So this is actually the study for beta, which was the first of its kind, and showed that both of these vaccines were working very well, actually, against beta, whether Pfizer or Moderna, and of course, and alpha was also similar. So vaccination has been very interesting during COVID-19 because the research questions never stopped actually from happening. There were always very interesting questions because right after variants, then the question became, how about waning of vaccine immunity? This is in fact one of the very first studies to show that vaccine immunity actually wanes and quite rapidly against infection, less so of course against severe disease. So with the waning of vaccine immunity, then we needed boosters. So we moved to assessing vaccine effectiveness of boosters. Later, Omicron arrived. So we had to look for vaccine effectiveness against Omicron and its many subvariants that continued to appear. And so on. So really, we try to address every relevant question that we can answer using our databases. In total, about 20 vaccine effectiveness studies. But this is really only one aspect of the work we have been doing. Our really interest was more broadly in the epidemiology of COVID-19. So we did lots of studies looking at the protection of natural immunity. In fact, the world's very first study was one of our studies, which showed very strong protection in the pre-Omicron era against reinfection. And we followed in a plan that was very similar to the vaccine effectiveness studies, where we looked at many different aspects. And here, similarly, here is actually the waning of the protection of natural infection against reinfection before even the introduction of Omicron, which showed also waning, but the waning was fortunately slower. Then variants arrived. So we have been looking at the protection of natural infection against the different variants, which was strong till Omicron arrived, where the protection was much less because of the huge immune evasion. And this Omicron study was also the first of its kind. So overall, we generated over 20 major frontline COVID-19 discoveries. I mean, by frontline discovery is a discovery where we were actually the very first worldwide, or at least one of the first studies worldwide to arrive at these answers. So the work was published in top journals. We had 13 papers published in the New England Journal of Medicine and tens of others in different journals. The work also in 4 guidelines, WHO, different country guidelines, and so on, was presented numerous times by us or by others. For example, Dr. Fauci in his White House press briefing, in US Senate testimony, and so on. It was covered widely also international press, New York Times, Washington Post, CNN, and so on. And I think the main really lesson here is that the region can definitely contribute a lot to generating really excellent quality research if we have the right investment in science. And this is really, I think, the most important message here. So just want before the end to emphasize few key ingredients why this really was possible. And by the way, for example, in the publications, the New England Journal of Medicine, in the history of our region, there was only one study published over there from our region. We added actually 13 studies only during the COVID-19 pandemic. So what are the key ingredients for success? I think the first one and most important one is this very strong working relationship between the academia and actually the government sector, which was really very, very special. And through this working relationship, we ensure that we have quality healthcare databases that can be used for research. Now, of course, we needed also the technical epidemiology capacity in the country to be able to utilize these data. And of course, we needed other components like genomic surveillance, as well as to support these studies. So that's it from my side. Thank you very much for listening.
Thank you so much, Dr. Laith. So now we have just two presentations for today's session. So I think that it's better to do the presentations, and after that, we will have the coffee break. So the next presentation will be done by Dr. Naif Al-Harbi. Dr. Naif, could you hear me?
Yes, thank you very much. Do you hear me?
Yes, we do. So you will share the slides from your side, yes?
Yes, I can do that.
Please, thank you.
Sorry, I thought you would take a break before my talk, so just bear with me. Yes.
We had some changes, since morning in terms of the agenda.
Sure. Do you see my slide now?
Yes, we can. If you can just put on slide mode. Yes, please. Thank you. Go ahead.
Is it clear now?
Yes.
Right. So this is some studies on vaccine effectiveness. Just give me a second, please. Sorry for that. So basically, I would like to start by saying that, as you know, I'm not an official representation of the countries because I'm not sure who was in that study from Saudi Arabia. But during my previous work before joining the Gulf CDC, I was working in the research center in the National Guard, and we have done a lot of studies in collaboration with the Ministry of Health in Saudi Arabia. So when I looked very quickly on the database, there are very few studies from Saudi Arabia. If you search for COVID vaccine effectiveness studies, it's only 34 studies, and most of them maybe not necessarily VE studies. And the research that we have done, we called it outcomes of single dose COVID-19 vaccine, 8-month follow-up of a large cohort in Saudi Arabia that was done in National Guard as well as the Ministry of Health. This was an observational prospect cohort study on more than or around 20,000 vaccinated individuals. We conducted the study early on from the first time, from when the vaccine first introduced in December 2020 until April 21. All received single dose and were followed up for 3 to 8 months because the last vaccination we recorded for the study was the mid of April, and the last follow-up was 10th of August 21. 18.5 thousand subjects met the study criteria. The criteria included no document COVID pre-vaccination or infection happening within two weeks after vaccination, or lack of PCR confirmation. And the data collection it's collected from clinical data, from medical records, and at the time we had best care. It's similar to CERNER presented by our colleagues in Qatar, and that was the system in the National Guard. We also have a self-reporting system for the adverse event in the infection control in the National Guard Hospital. And we have the national data from the Ministry of Health, which shows the COVID-19 infection history or status. And if for those who are familiar with the country, maybe you're familiar with the Tawakkalna application, which is the national application during the COVID and now still there. So in the application, the Ministry of Health will update your status linked to your ID, if you are infected or not, if you're vaccinated or not. So we had access to Dr. Abdullah Asiri, the Deputy Assistant Minister, and his team, and they allowed us access to follow up our cohort and to have actually more rigidity in when we say this is infected or not infected based on the national data. The only thing we might have missed is if there is an asymptomatic case and those people never ended up in testing, or people who asymptomatic but not tested. But sometimes if they are asymptomatic but they're testing for travel purposes or Hajj and Umrah purposes, we might have captured them. So out of those 18.5 thousand vaccinees, 2% received, 2.3% received Pfizer vaccine, and 97% received AstraZeneca vaccine. From early on, we were not able to, I mean, the number are very, very different. So we were not able to do the study by vaccine type, although we analyzed that. 60% were male and 39% were female. Largely, they are young people. So we're talking about a median age of 33, and the body mass index was higher. So it's 27. This is the comorbidity and characteristic of the subject, and it's analyzed here doing the chi-square, statistical significance. So you might appreciate that the column on the right hand of the slide, the no infection post-vaccination, those are 17,000. Infection post-vaccination, which post 3 weeks from vaccination, are 1,452. When we did the analysis, the significance were found in the gender. So male were more prone to get the infection. Nationality, for some reason, the Saudis were more prone to get the infection. You can see here that in those who got the infection, 80%, 81% were Saudis, 18 were non-Saudis. And diabetes mellitus, diabetes were also significantly higher in those who get the infection, morbid obesity, and organ transplant. It's quite interesting to mention that the malignancy, asthma, those patients usually take some medication that could reduce their immune response, but they did not show up here as significantly higher when it comes to infection post-vaccination. And this table here shows the multivariant logistic regression analysis for the modeling the probability of the COVID-19 infection post-vaccination. It's higher in male, Saudi, and obesity, with these p-values showing here in the table. So moving now to the adverse event, only 1.1 thousand reported adverse event in the self-system and the self-assessment reporting system, mainly injection site pain. We didn't see any unusual adverse event, to be honest, but this lack of adverse event, it doesn't mean the absence of it, because it's a self-reporting system, and we're not sure if other people never get the adverse event or never get it to a level that they want to feel to report it. And when we analyze the time between the vaccination and the infection, and those who got the infection after the vaccination, we could not find any significantly higher period of time, if you like. So if you look at the figure here, from 15 days, 25, 35, these days are divided by interval of 10 days. More or less are the same, with from 3 to 8% of the infection happening every 10 days. We did some analysis to see if there is any effect of the comorbidity or characteristic on the duration of the infection, but no statistical significantly higher, except maybe if you can look at the morbid obesity, it's higher there. The nationality kind of almost just above the borderline. So we did not find a significant message from when the infection happens and related to any of the other cofactors. We also did the same table on vaccine type. but there was no significant difference between the two vaccines. But we need to know that the Pfizer vaccine was very, very low number in our cohort. So the message we got here is, or the conclusions, a single dose of Pfizer, either this is a single dose early on in the vaccination rollout. And the reason for those who are wondering why we followed some people for 8 months, because at the beginning, the government decided when there were some challenges in the distribution or the supply of the vaccine, they decided to go with single dose for a higher number or as much as possible, as many as possible, and delaying the second dose. So the protection rate in our cohort was 92% in those 3 to 8 months. And you can appreciate that in the clinical trial setting, the protection of the vaccine efficacy was 52 after 1 dose of Pfizer vaccine and 95 after the second dose of Pfizer vaccine, or 70% after the AstraZeneca 2 doses. Number 2, diabetes, organ transplantation, obesity, as I said, they were not associated with risk of infection post-vaccination. Saudi male obese subjects were more likely to post-vaccination infection other than other group. And I mean, especially for Saudi, we were talking about socioeconomic status, sociology, any other social interaction that might happen, because the study was conducted the time where travel restriction, moving into places and mosques and other social setting. So I think, and we thought at the time, and we discussed it, that there might be something about mobilization, movement of people, Saudi versus non-Saudi. The vaccine type did not impact the number of days, as I said, and lung and asthma and cancer who have the treatment and chemotherapy, which is known for predisposing microbial infection, did not impact or did not show any likelihood of more infection in the vaccinated cohort. So if you allow me now, I want to move quickly to a few figures from another study follow-up that we did on this cohort, assessing the immune response in this cohort. So the graph A here shows that the baseline, already we have some baseline positive antibody against SARS-CoV-2, boosted by vaccination post-prime and then post-boost. And then after 6 months, it's a little bit waning. And we were following the Qatari study at the time where it was leading the way for informing us and during this study. And 12 months, we only had a few people, so it doesn't add much. But then when the booster dose, the third dose was introduced, you can appreciate that the antibody level were higher even than the peak, which is the post-boost. Also, the convalescent plasma compared to other graphs here. In the graph B, where you see the brown and the pink, the brown is AstraZeneca, pink is Pfizer. We did not see much difference between the two vaccines in terms of antibody after prime or after boost. And then both of them were higher than the convalescent natural immunity. And we did some biosafety level 3 culturing of virus and doing neutralization just to confirm that the antibody are neutralizing, but we saw big differences in terms of the magnitude of the antibody, neutralizing antibody. We were not able to link it to the outcome of because it's a small sample, but we just wanted to do it as a proof of concept that these are neutralizing antibody, more to technical proof of the previous slide. So whatever the in-house ELISA study that we did is confirmed by neutralization assay. And here we looked at graph A, we looked at the people who got the infection before, so the pre-infected or naturally infected, and then vaccinated. So the open symbols are infected, and the blue symbols are not infected but vaccinated. And you can see there's no much difference, especially after the boost. I mean, after the prime, yes, you could see that those with the natural infection might be higher than and those who did not get the infection previously. But after boost, you kind of seeing the same level whether you are infected before or not. We looked at the interval, and that was an interesting debate at the time because interval, some countries were pushed or they're pushing to increase the interval between the boost and the prime. And we found that when you increase the interval from 3 weeks to higher, you increase the antibody response overall. And so if you allow me quickly just to share some, I think for the challenges and lesson learned, the data is electronically available. And I second what my colleague, Dr. Abu Raddad from Qatar said, that we could show that the region is good, well established, or could be well established could be well set for these studies. Just need some good coordination and linking and capitalizing with the electronic systems that are available. But also you need the right channel of approval and communication to conduct the study. But you also need a dedicated team for cleaning analysis of the data. Our study did not include a comparison group, and I think Daniel this morning showed the importance of a relative or absolute VE, and the selection of your control group would mean a lot. In our cohort, we did not have a control group. We just followed up that prospective cohort study. Vaccine type for us, we could not select it. Basically, it depends on what was available in the country at the time. And safety and adverse events rely heavily on the self-reporting. Lab testing requires huge logistical support, and that's why we did not went high with the number of samples, especially for neutralization. We did other study on transplant, kidney transplant. We also looked at the salivary antibody correlation between the salivary IgE and the systematic IgG, sorry. But these were published. I don't have time now to present them. So with that, I would like to thank the organizer for giving me the opportunity, and we're willing now at the Gulf CDC, we're happy and willing to be engaged more and to have more work in this consultative technical meeting. Thank you so much.
Thank you so much, Dr. Nay, for your great presentation. So we will listen to the last presentation from Dr. Nawal. And after this presentation, we will open the floor for any questions that you have from a study in Qatar, in Saudi Arabia, and also for Tunisia. Sorry, UAE. Thank you.
Thank you again for inviting me to present this study. I'm Nawal Kabi. I'm a pediatrician infectious disease physician, and I was the chairperson of COVID-19 national clinical team and also the PI of many clinical trials in UAE plus the real world data. So this is the study I'm presenting. We publish it in Nature Communication. Now, as a background, UAE collaborated with Sinopharm to conduct phase 3, and we conducted across 4 countries, but most of the recruitment was from UAE. And the phase 3 trial showed that 2 doses of inactivated vaccine 3 weeks apart was about 78% effective in preventing symptomatic COVID. And UAE granted emergency approval for frontliners in September 2020 and for the public in December 2020. And WHO approved the Sinopharm inactivated vaccine in May 21. And UAE has one of the highest COVID-19 vaccination rate worldwide. So it is a retrospective cohort study. It includes all individuals 18 years and older, and the data was extracted from Sahha, Salamatic System, and Malaffi database. Now, this is the EMR, and in Abu Dhabi, all EMR are integrated under Malaffi. So regardless where the patient seen, private or government, which hospital, or integrated under Malaffi. And Sahha, it's the largest network. It operates the public healthcare facility. It provides the COVID-19 vaccination. It manages all the COVID vaccine related issue, and it runs COVID-19 hospital in Abu Dhabi. So in Abu Dhabi, we have a dedicated hospitals for COVID during the pandemic. In terms of the outcome and covariate, we investigated vaccine effectiveness for 3 COVID-19 outcome: hospitalization, critical care, and death. I'll skip this part as I will not go in details into statistical analysis. Our objective was to evaluate the real-world effectiveness of 2 doses of inactivated vaccine against those 3 outcomes, and to assess the vaccine effectiveness decline over time for each studied COVID-19 outcome. If you look at the study population, 1,832,000 individuals received 2 doses of the vaccine before July 1st, 2021. And 1,315,000 unvaccinated controlled had not received any vaccine before July 1st, 2021. We used rolling entry matching, REM. A procedure was used to match 1,153,515 vaccinated individuals with the equal number of unvaccinated control. And the match was based on age, gender, and it resulted in 1-to-1 ratio between the 2 groups. We excluded those with the previous hospitalization of COVID. We excluded also those who received different type of vaccine. This is the demographics of the 2 groups. They are more or less very similar. In terms of overall effectiveness during the first 3-month follow-up, there was 3,505 related hospitalization, in total 2,889 in vaccinated compared to 606 in unvaccinated versus 616 in vaccinated. For the critical care, 653, 574 in unvaccinated compared to 79 in vaccinated. And there was a total of 99 deaths, 87 in unvaccinated group and 12 in vaccinated. The vaccine effectiveness at 3 months post-complete vaccination was 79.6% against hospitalization, 86% against critical care, and 84% against death. I'll explain this in the next slide. So if you look at the COVID-19 hospitalization, the higher effectiveness was in female compared to male, higher effectiveness in individual below 60, and higher effectiveness among individuals with comorbidities compared to those without comorbidities, and higher effectiveness during the month of October to December. For critical care, higher effectiveness among male, and higher effectiveness in individuals with comorbidities, and higher effectiveness, of course, between October to December. In terms of death, highest effectiveness was observed in patients with comorbidities, and higher effectiveness during the month of October to December 2020. In terms of waning of effectiveness, for hospitalization, it declined from 82.8% at 2 months post complete vaccination to 62.1% at 6 months post vaccination. While there was a gradual decline in vaccination in effectiveness, there was no further decline after beyond 6 months. For the critical care, it declined from 85.7% to 72.8% at 6 months, and no further decline after 6 months. And the decline in effectiveness against the critical care was similar to the hospitalization. Remember, we followed them up to 1 year. We didn't see what happened after 1 year. Now, the study finding indicate lower effectiveness compared to a secondary analysis of phase 3, which reported 100% efficacy against severe COVID-19 cases. So that probably due to different reasons. One, this is a real world data. It includes everybody, including high-risk population. And we followed patients for a longer duration after vaccination. Of course, another good reason, the emergence of newer variants of concern, especially that phase 3 was done while the wild type was around. We found that vaccine effectiveness against hospitalization decreased with age, especially those older than 60 years of age, and this was seen also in other studies. Now, the vaccine effectiveness in older age group might be underestimated in UAE, especially in Abu Dhabi, because we do have a regulation during the pandemic that we have to admit any positive COVID who's 65 and above, regardless their status. And the reason that the government, they want to protect those vulnerable population. And also we observed there are fewer deaths compared to other study. Again, it could be because of our proactive measures and hospitalization high-risk group, including elderly, regardless their insurance. And another reason maybe because all COVID-19 patients receive standardized treatment in a dedicated hospital. So the team become really very competent in looking after COVID patients. Now, vaccine effectiveness was very high in October to December, and probably again because of the wild type at that time, and the authorization initially was given to the frontliners and later on to the public. The decline in effectiveness, okay. The decline in effectiveness over time could be due to the emerging of the variant of concerns, which was seen that it escaped the immunity that was in response to vaccine. It also could be because of decline of antibodies over time, and this was seen also in other studies. Now okay, I'll skip this. So our strength, it utilized a large comprehensive data set covering the entire population of Abu Dhabi. We managed to match data for age, gender, comorbidities, ethnicity, and observation month. And it provides nearly 12-month follow-up period to look for the overall effectiveness and effectiveness across different risk factors, and also waning of effectiveness over time. Our limitation, we focused more on the severe outcome. We didn't look at the effectiveness against symptomatic infection. Also, we didn't look at specific organ injury. And we managed to adjust for many factors. However, we didn't adjust for obesity, smoking, or occupation. Although we analyzed the decline in vaccine effectiveness over time, we couldn't entirely rule out the impact of changing circulating variants on waning of the effectiveness. And we did not include infection as an outcome because we did actually UAE extensive COVID-19 screening, so it was a little bit difficult to include the infection. Thank you so much.
Thank you, Dr. Naval. So now is the time for any question, feedback, opinion, if you have regarding these three presentations and the studies from Qatar, Saudi Arabia, and also UAE. Please just colleagues online, raise your hands, and colleagues here. Okay, Dr. Najafi, please go ahead.
Yeah, okay, thank you. Thank you for presentation from Saudi Arabia and United Arab Emirates and Qatar. I have one question from the study by Dr. I think Naif, from Saudi Arabia. Actually, it was a great job, but I'm thinking that whether you actually calculated the vaccine effectiveness or not, because you didn't compare the, vaccine status between two groups or cases and control. You mentioned that you calculated the protective rate for vaccinated group, but I'm wondering whether actually you can interpret it as vaccine effectiveness or not, This is the first question. And the second one regarding the study in Qatar, I mean, the question is that how did you, can you just describe it in more detail about the method of the study for waning of the natural immunity? How did you run such a study? Okay.
Thank you, Dr. Najafi. So we can, Dr. Naif, please go ahead, and then,
Yes, thank you very much. I think this is one of the weaknesses of our studies, that we did not have a control group to compare it and to do the effectiveness studies. And that was also reflected on our publication. So we just called it outcome of single dose vaccination. It would be very better. It would be better to have it a proper vaccine effectiveness study. But I'm sorry, that's what we are able to do. Yeah, that's it. That's in short. Thank you.
Thank you so much, Dr. Lace.
Yeah, for us, for the very specific study that I've shown, that was actually a cohort study. It's a retrospective cohort study. But we did, in fact, look for both vaccine and natural immunity using both, test negative designs and also cohort designs. And actually, the results are similar. In fact, in one of the studies, we applied for the same time for the same database, both a cohort design and test negative design, and both of them gave us actually identical results. Yeah.
So does it mean that you follow the patient without any vaccine for a long time, and then you check the antibody? Is that correct? Is that the way that you?
We did not. We do not check for antibodies. We use only records of documented infections. But the good thing for us, because in reality, what we have is a cohort of the entire national population. We know everyone when they get vaccinated. We know everyone whether they get tested positive or negative, and so on. And we had a huge amount of testing, similar to UAE. So we were testing actually 5% of the population every week. So we had a very good capture of actually infection. Of course, we missed many infections.
Yeah.
And this is in fact relates to your earlier point. I don't think this has been an issue for us, in part because of the high testing. But also some of the designs, by the way, they are less sensitive to misclassification bias. In particular, the test negative design, even if you can actually have significant misclassification bias for prior infection, and still you will get unbiased actually result. So I don't think this really has been a major issue for us. Now, moving in the future becomes more tricky because now we don't have as much testing. There are lots of undocumented infections and so on. Yeah.
We have follow-up question.
Yeah. Thank you very much. Actually, I was putting the same question of Dr. Najafi to Dr. Laith, acknowledging very much the contribution of Qatar in this huge number of vaccine effectiveness study from the region perspective and from the global perspective. Knowing actually the vaccination day by day in all countries in the region, and Qatar was one of the first countries who have introducing the mRNA vaccine with a high coverage from the beginning, like UAE and Saudi Arabia and so on. So I was just taking the word of waning natural infection immunity. So waning means that I have pre and post. So I have two levels going down. So what was the level in the beginning that I have seen going down in a cohort of people who have never been exposed to vaccination? This is natural infection. So here, I just wanted to formulate the same question in another way. From this word and from the study design point of view, I have a cohort who have been infected and I recorded this infection. I have registered the immunity level. I followed up with for a period with no vaccination, and I found this immunity waning. This is my perspective. So was it the design or something else maybe I didn't capture? This is my first question to you.
I'm not sure if I captured exactly the question, but your question is whether natural immunity wanes?
Exactly. This is the title. Natural infection, waning immunity. So these four words mean that I have a cohort of people who have been infected, and I documented they have been infected, they are not vaccinated, followed with them for a certain period, and I seen that the immunity has been waned.
Oh, yeah,
So
yeah.
how this has been done in a country who had the vaccination from the early beginning so high?
Yeah, okay, and all of these are controlled studies. So when we looked at vaccination, or if we looked at natural immunity, we actually control for the effect of the other immunity. So there is no issue about control action. Now, why is the immunity wanes? Oh, I think it's probably something generic for all respiratory infections. It has to do with the mucosal immunity. We cannot really keep lots of antibodies in the upper respiratory tract, because if the body actually will keep high concentration of antibodies in the upper respiratory tract, we need a huge head in order to keep that many antibodies, because this is where lots of actually pathogens enter. This is why it's really, by the way, feature for all respiratory infections. We cannot have long-lasting immunity. The difference, however, between vaccine immunity and natural immunity is mucosal immunity is stronger for natural infection. Why? Because the challenge comes to the nose, to the upper respiratory tract. So there are more concentration of antibodies actually over there. Vaccine is systemic. So actually not as much antibodies go to the upper respiratory tract and last as much. This is why a stronger protection of natural infection. But it actually wanes, even without any changes to the virus. We do not actually, according to our data, it would not have lasted for more than actually 3 years. That's it. Natural immunity will always wane against respiratory tract infections. This is why now, of course, one of the great ideas is why don't we use nasal vaccines, in fact, to try at least to boost mucosal immunity longer for current vaccines. Yeah.
To have more surface IgE antibodies rather than IgM. This is something maybe we can discuss some details, but I'll come to my question to Dr. Naif now. For the third conclusion point, Dr. Naif, you have kindly mentioned, or you have been analyzing males as a gender and obesity as a confounding factor. And you have been mentioned that male obese are prone more infection than other infected. I think it should be other than vaccinated. So can we look at the wording of the third conclusion point, please?
Yes, I will double check. I don't have the presentation now, but I think the conclusion was in our cohort. It's a
conclusion slides. There was a conclusion slide before the screenshot of the published manuscripts. There was a conclusion, I think, of 5 points. Number 3 was bolded, related to male and obese.
Yes. Number 3, yes, we're more likely to get post-vaccine infection than other infected group. Sorry, than other vaccinated group.
Thank you. This clarifies.
This is a chance for me. Thank you so much. This is a chance for me to also highlight one thing that's related to the discussion just being heard now. That's in these studies, I think we need to be careful or considerate of the context. And it's a cohort study. Yes, there is a high level of vaccinated people. So you don't have the ability or the freedom to have a control group or non-vaccinated. And I like what Daniel this morning said. He said, now we're changing the control group from non-vaccinated to vaccinated, but different group. That's one point. The second point is, like, if you look at our study, when we started, we said, okay, we follow up for 3 months, sorry. But then because there are some delays in vaccine supply, we kept following up for 8 months in some of them. The third point is that antibody response at 1 year. So after 12 months of the second vaccine, of the second dose, we only get 4 samples out of 600 or 700. And that's why, because some people, because the new policy came with the booster vaccine, and most of our cohort already got their third vaccine by that time. So I would like to see these studies as dynamic with the context and the supply chain and the changes in policy. Thank you so much.
Thank you, Mr. Shiraz. Oh, so I saw your hands on, so now you just Go ahead, please, if you have any question or comments.
Yeah, thank you so much for both the study. Wonderful work done. My question regarding the Saudi Arabia study is that it has been mentioned when you started the presentation that the study was from December to April. And that is a total 5 months. And then you said that the total follow-up period was 8 months. The second question is that the median time was 82 days from vaccination till infection. So I was just wondering whether it was for the partially vaccinated or it is after the complete vaccination of the study participant. Regarding the Qatar study, it was mentioned that the deaths in the unvaccinated group was around 90 to 94, and in the vaccinated group it was 12. So, as you had a policy, national policy of the high risk group to be hospitalized, despite the severity of the disease. So, I was wondering that could that distribution be segregated by the age group? And second question regarding the Qatar University, the Qatar study is that how when you started the study, so you were having a lot of people who are unvaccinated, but you have a 1 year follow-up study. So how you cope up with the vaccination of the unvaccinated participant over the study period? Thank you.
Thank you very much. Let me start. So thank you very much. Those are good questions. The first question is about the timing, because we started vaccinating in 17th of December 2020, and the follow-up for those people who get the vaccine early on were up to 8 months, but people who get vaccinated in April were followed for 3 months. So not all the cohort were followed from 3 to 8 months, but up to 3 to 8 months. It depends on their vaccination status. So when related to your second question, whenever they get the second vaccine, that's where we don't include them in the study, because we were focusing on the single dose at the time. And the duration of the infection, it's 82 days. Sorry, your question about the 82 days, what was the question?
So the question was that the infection was after the participant is fully immunized, whether it was first dose or it is after the second dose. But I think you answered that question, that the participant who were single dose, so you actually followed those.
Yes.
Thank you.
All single dose, 3 weeks after the single dose. Thank you.
Thank you, Dr. Nabil.
I want to comment about the conversation between Dr. Kamal and Dr. Light regarding the waning of the immunity. Re-exposure, there will be memory cells that will be stimulated and rising of the antibody occur. But what's about the nasal vaccine is to introduce the secretory IgA. It is not IgG or IgM. It deals with IgA, which is a secretory related to the mucosa. So it gives double protection to have the secretory IgA in the nose at the site of the entry of the virus. That's all that I want to clarify.
Yeah, this is correct. And this is basically what maybe I misspoke or something, but this is exactly the point. It's a question of mucosal immunity. That's actually.
We have a study with Dr. Iman about the effectiveness of hepatitis B vaccine, and the role of the memory cells is quite evident. And we have published this article in Vaccine. It have a lot in order to re-exposure and introduction of the stimulation of the memory cells, and thus have protection against the hepatitis B virus itself.
Yeah, I think there were also 2 questions for me from Shiraz.
Shiraz, have you had any questions from Qatar also? From Dr.
Yeah.
Light?
Yeah, so there were 2 small questions. The first one is regarding the deaths. One of their outcome was death So in unvaccinated, it was around 90 to 94 participants who died over the study period, and in the vaccinated, it was 12. So I was wondering that because they mentioned that for the participant who were 65 years or above, so their national policy was admitting them to the hospital regardless of the disease severity. So I was wondering that whether the deaths can be segregated by the age group, that in which age group specifically the deaths occur. The second one was when they started the study, so they were having a lot of people who were unvaccinated, and they followed them for a period of 1 year. So whether there were some participants who get vaccinated over this 1 year period, and if yes, so how they looked into that and incorporated that into the study results.
Yeah, so in relation to the second question, really great question. So what we use are basically dynamic cohorts. So everyone gets followed up. If they are unvaccinated, the moment they get vaccinated, they move from the unvaccinated cohort to the vaccinated cohort. So we captured everyone, and they always entered exactly according to their vaccination status. So this is regarding the second question. For the first question, just like in UAE, we had very proactive policy in relation to dealing with hospitalizations for COVID-19 patients. I mean, we are fortunate, we are in a very resource-rich countries that we are able to do so. We did not have quite the same policy about 65. It was really at the discretion of the healthcare, whether they saw there are enough morbidities, etc., for hospitalization. However, this really never affected our studies, because we never use hospitalization as a marker of severity. We always applied the COVID-19 severity, criticality, and fatality per WHO criteria. Every COVID-19 hospitalized case was followed every 3 days, and then we changed the severity assessment for this patient, whether it went to severe, critical, or fatal, and so on. So it never really affected the estimations of our vaccine effectiveness studies. Yeah, but great question. Thank you.
Colleagues here or online, any further question? So please.
Yeah, just one point. The last your last description about how you follow the patient for within a cohort probably is the correct answer to my question. I mean, the way that you run the study was following the patient until they get the COVID-19, and then by doing this, you check the national immunity waning. Thank you.
Thank you. I want to also join the compliments to Qatar for contributing to the public health, global public health in terms of guiding vaccination. So congratulations. My question is to Dr. Nawal. You mentioned that you follow up COVID-19 related hospitalizations. I just want to know, what do you define as a COVID-related hospitalization? Is that set of symptoms, or you have a case definition for that? Thank you.
Okay, so we use a code looking at is COVID-19 the primary diagnosis for admission, or it is a secondary diagnosis? And then we, if there is any file record that is questionable, then a separate team will review that case. So we are depending on the codes that are used when we capture the cases. Yeah. So the one who capture all the cases is there are two data analysts. They are not clinician, so they have a set of codes that they are following to capture the data. And then the analysis was done by statistician. The writing and was done by clinicians. So we are trying to be very, everyone should do their own specialty, so there's no bias in data analysis. And actually, this is similar to Qatar, where we collaborate academic plus the clinician. So 2 universities involved, plus their regulatory department of health, plus us as a clinician and researchers. So we all work together for this study.
Thank you so much. I myself also have a comment. I mean, so we were discussing with Kamal also that now we have also some studies, done, for example, in Emirates, we have Qatar, Saudi Arabia, Tunisia, Morocco, and we are thinking that if we can also pull our data all together for these 4 countries that, they just was included in the regional COVID-19 vaccine effectiveness study. So then we will have more countries, about 10, 11 in our region. I think that it will be a very rich study, powerful, results. So this is also what we are thinking. So we can discuss this later. It would be great if you can think also yourselves that if you also wish to have this. So we have our consulting, team with us. I mean, Carson, Thomas, and Manuela. So they can guide us that how we can pull also these results all together. I don't know, maybe through a kind of meta-analysis to have one study all together regarding the COVID-19 vaccine effectiveness studies done in the region. So any further comments, questions, colleagues here, colleagues online? Okay, so do you have any question, Dr. Nawal? Oh, okay, so that mic is on. Okay, so I think that we can just end our session today. Thank you for your great collaboration, cooperation, also interactive sessions. I also want to thank colleagues online. Thank you for being with us for the whole day. And we hope to see you again tomorrow. We will start tomorrow at 9 according to Cairo time. Please join again. We want to, benefit from your experience and from your knowledge regarding this kind of studies in the region. So again, thank you. So the coffee break is ready, and the shuttle will be in front of the building at 4:30 to take you to the hotel. So please help yourself, and then you can go in front of the building just to go to the hotel. Thank you so much. Thank you, colleagues. Thank you, everyone. See you tomorrow again. Thank you. Bye-bye. Yeah, we can clap hands. It's it was very dry ending.